So day is here. We are supposed to start the workshop for the day. So before I start, let me invite Dr. Bal Gopal Karmachare. He is the chairperson of the scientific committee. So Dr. Bal Gopal.
Namaste and good morning to all. Welcome you all in the pre-conference workshop today. So today till 2 p.m. we'll be here in this for our pre-conference workshop. The initial 2-3 hours will be dedicated for kyphoplasty and vertebroplasty. That will be taken by Dr. Amit. And after that, we will get the workshop on the Inauguration. Dr. Malcolm SWD has come all the way from Mumbai to teach us how to do the basic steps of the lecture. Let's start.
So before I start, let me invite Dr. Malcolm Dastanji with this particular khana. Sorry. We appreciate your answer and we will learn a lot from you. So, guys, Dr. Dastanji is a leading figure in the world of endoscopic spine, and it will be appropriate for all of us to interact with him as much as possible. He's a very good teacher, and we hope to learn a lot of things from you, sir, today.
This is for Professor Amit. He is the chairman of the spine chapter of NESON. Yeah,
So, as we were discussing before, this particular spine specialty has been evolving over the last 3-4 decades in a very rapid pace. In fact, after being trained as a neurosurgeon, when I started practicing, I found that a lot of things in neurosurgery may not have changed as fast as the spine. And the endoscopy thing has come in such a rampant manner that now through endoscopy, you can even put a cages and fuse the spine. Initially, we were using endoscopy only to decompress the spine or the canal or the foramen, but now even the fusion procedures are done. And on top of it, for the pain procedures like kyphoplasty and vertebroplasty has become the routine procedure for any neurosurgical practice these days. So henceforth, we decided why not to put this 2 new advances in our workshop, which will be of help to all our faculties. So we begin the day with kyphoplasty and vertebroplasty. So the arrangement of the workshop has been that first of all, we'll have a small discussion as to what procedure we are going to do in the line of this particular presentations. And then we will let you know how to work on a cadaver. And then we will leave you with the cadaver for another 45 minutes to 1 hour. So that's how we're going to proceed. But we'll try to finish this kyphoplasty and vertebroplasty thing by 10 o'clock so that you will have ample of time for hands-on for endoscopic thing, which is something new to all of you. So kyphoplasty and vertebroplasty, also known as vertebral augmentation. So in augmentation means that you are actually making the bone much more stronger. You are augmenting it. Okay, so this augmenting thing, also known as percutaneous vertebroplasty, when it was first started, was coined by Galibret and Deramont for C2 hemangioma. As you know, hemangiomas are the most common benign tumor of the spine vertebra. And usually they do not present with any symptoms, but then in some patient, it may present with pain, and then other patients may have some pathological fracture because of it. So in 1987, it was first started by Gilbert and Deramont, and balloon kyphoplasty was later on and they were described by Garfin, and it was only in 1998 that it was first approved by FDA for use on the clinical patients. Now, what does it that because we all know the loss of stiffness in the body actually makes it susceptible to deformation, and that's why we have a lot of kyphosis in thoracic spine as well as a lot of lordosis in the lumbar spine because of the failure in stiffness of the vertebral body. So this loss of integrity of the vertebral body leads to fracture, and then it actually loses. Can somebody pick up this phone? So this percutaneous vertebroplasty actually increases the elastic modulus, and it provides ultimate strength or stiffness to the augmented vertebra. Now, in that sense, it also produces, or rather creates, a sort of a mechanical stability by reducing the micromotion of fracture segments. And that's why it leads to the clinical improvement in pain as well as regainment of the vertebral height and collapse. Now, it has been shown that by using percutaneous vertebroplasty, you can actually increase the stiffness, and because of which the strain or which is put on the nucleus pulposus can also be relieved over 20% in cases. Now, the literature has shown sufficient evidences of clinical improvement, and what has been shown that it is very effective. You can use this procedure within 6 weeks in the terms of decreasing the severe pain, and it is very effective for fractures which has occurred within this 1.5 months. And the meta-analysis has shown that decreases the reduction of mortality by, in 12 months, as well as morbidity by 19% and 36% respectively. And 10 years mortality has also been shown to be reduced by almost 22%. And henceforth, it decreases the health cost involved by using these procedures. Now, this is a slide which actually compares the effectiveness as compared to the conservative management and other non-surgical treatment. And this is something which is already very much in use. So we are just going to skip it. Now, the terms vertebroplasty and kyphoplasty. Now, vertebroplasty means that you are just injecting some cement inside the body without trying to confirm its shape or regain its shape. However, balloon kyphoplasty is a procedure we like to expand the vertebra, the collapsed vertebra, so that we can actually create a vertebral alignment, and then you put in a cement. Now, the difference between the two is that vertebroplasty will only aim to create a healing, to help heal the cracks. But then the kyphoplasty actually creates a cavity inside by inflating the balloon. Henceforth, when you're injecting the cement inside the bone, if you're only doing vertebroplasty, you will have to push the cement in a high pressure. However, since the balloon has already created a space for itself in the balloon kyphoplasty, you don't have to inject the cement in a high pressure. Now, what's the advantage? The advantage is that when you're injecting anything under high pressure, the cement will like to go in the places of least resistance, and that creates embolus. That creates misplacement of the cement, right? That actually pushes the cement into the area of the least pathway, and that may be the epidural veins, the Betsonian plexus. So all the veins, all these cements can go into those cement plexuses. However, in the balloon kyphoplasty, since you are not injecting the cement in that much high pressure, chances of embolus or malpositioning or misdirection of the cement is very, very lesser. And on top of it, since you are correcting the height, the kyphosis part, there will always be a reduction of the deformity, which is seen in the balloon kyphoplasty, but not in the vertebroplasty. And since we are, the cement which is also used is also different, because the amount which you use, since you are injecting in a very high pressure without making a space for itself in the vertebroplasty, not more than 4 mils of cement may be injected inside when we're doing a vertebroplasty. However, since you already created spaces inside with the help of a balloon kyphoplasty, you will have a lot more cement which can be injected, and henceforth the strength can be built up. So these are the major differences in the balloon kyphoplasty as compared to the vertebroplasty. Now, what are the indications? So it all started with osteoporotic fractures first, because the patient do have a lot of this particular technology help you to avoid. Well, I can hear somebody speak in the crowd, so please mute your speakers. Okay, so osteoporotic fracture is one of the indications for the vertebral augmentation, followed by traumatic fractures. Now, the literature is full of reports where the traumatic fractures can also be helped with vertebral augmentation, with or without instrumentation. Right? So what instrumentation does, it actually gives you a posterior support, but then if in case you need an anterior support, you can even fill it with the bone cement by going with a balloon kyphoplasty, and then provide an anterior support to the posterior support with the along with instrumentation. Then in the benign lesions like vertebral hemangioma and giant cell tumors, then a lytic metastatic vertebral body disease like multiple myeloma, metastasis, lung and lymphoma. Now, even in the vertebral metastasis, people have shown that after you put the needle inside, you put an RFE needle inside the vertebral body, and then kill the tumor cells by heating up the vertebral body by almost 15 minutes, and then you inject the cement. So that's how it can even give you some amount of control for the metastasis which has occurred inside the vertebral body. The most favorable MRI features which has been seen in the stitch sequences is the presence of marrow edema, because that actually tells you that the patient has an acute or a subacute type of a fracture, and in that sense, the vertebral augmentation helps a lot. Then what are the absolute contraindication? If the patient has septicemia, you should not put it. If there's an active infective foci in the vertebral body or the disc, if the patient has a bone allergy to the bone cement, and uncorrected coagulopathy, which is basically more or so contraindication for most of the procedures like this. The related contraindications are that the posterior fragments, there's a retropulsion of the fractures leading to the neurological deficit, because that makes an indication for decompression and repair. So that's why if in case you see any retropulsion of the fracture segment, then you should not only embark on vertebral augmentation. Any systemic infection, canal compromise, secondary to epidural tumor, improving patient conditions with medical therapy. So that means there is another thing, patient is improving on his own. So why do we want to jump on intervention? And prophylactic measures in osteoporosis is being taken, then you can actually allow the patients to heal on its own rather than going for an intervention like this. And other than that, there is another contraindication is the intactness of the posterior element. Why? Because all the cement which we are injecting inside the patient's body, this is going to be creating heat inside. So if by chance any bone cement comes into the epidural space, then it's going to harm the patient's cord, patient's nerves, isn't it? So that's why, and we need to see the intactness of the posterior cortical element. So that is very important for us. Now, most of the procedures are done under local anesthesia or conscious sedations. Rarely we use GA. And then I cannot see this screen, okay. And then the patient has to be put on a prone positions on bolster with a radiolucent surgical table. And the patient, we usually give a single dose of intraop methylprednisolone and antibiotic. It is just like any other procedure which we do on the spine. And then we can go ahead with this. So you don't need to have a Wilson frame for all the patient. We can just keep the two towels. Idea is to keep the spine in a perfect alignment. So that the thoracic kyphosis as well the lumbar lordosis is maintained, and we need to have a little bit of extension in the lumbar spine so that the patient's there's a compression collapse fracture, it reduces to some extent by its own. Then the radiographic equipment which we require is basically a C-arm. It always makes a good point if you have a 2 C-arm, right? Or in case you want to perform this particular procedure in a biplane cath lab, then it is a hella luxury. Right? But then the best part is that you can do it in the AP and the lateral view projection at the same time, then they don't need to keep on changing the CM. However, this is not a very fixed requisite. You can work with even a single CM, which we will discuss in the subsequent slide. Now, purpose of the imaging is definitely to identify the disease level and then to analyze the spatial relationship. And then those 5 points which I have marked on the screen, this is the 5 points which everyone should be aware of while trying to do this procedure. And then to confirm the proper angulation and placement of kyphon instruments. So kyphon is basically a Medtronic trademark product. And then we have to monitor the inflatable balloon tamp. That is the balloon which we are inflating inside the bone, and whether the bone cement is filling or not. So these are the things we'd like to see on a CM. Now, this is a very important slide because this is something which we always want to achieve on a patient before starting the procedure. That is a true AP and the true lateral. Now, whenever we say a true AP, that means that the pedicle should be very well seen, and the pedicle should be touching the upper half of the upper level of the cortices, and both the end plates above and below should be parallel. Okay, so there should not be any parallax, right? There should not be multiple lines seen on the upper and the lower vertebra. Now, sometimes what happens is because of the compression collapse fracture, this level may not be that much well seen. Okay, so if in case that is the case, then you just try to keep the pedicles in the upper half of the vertebra. And the second thing we have to see is the distance of the spinous process from the lateral margin. So it should be equidistant. So if your C-arm is a little bit rotated, then you may find spinous process drifted to one side. Okay, so that should not be the case. You should always keep in a true lateral position. And this is very important. And you will understand this much further in the subsequent slides. And then in the true lateral, we have to be careful that the pedicles are superimposed on each other. So that again, the pedicle should not be seen at two different levels. The parallax should not be created and the end plates are parallel. So this is the starting point. You should always try to maintain this particular starting point before we jump on the further projections. Now, the flow of work is to, first of all, get an access inside the vertebra through the Jamshidi needle. Now, Jamshidi needles is something which you can use in your own setting. You don't need too much of needles as is laid on the table. But then since this is a Medtronic sponsored event, so we are trying to show their equipment here. So we will start with an access device, which has basically a taper end. So this is known as taper cannula. Now, this taper cannula has a stylet inside. And through that stylet, the other things can go inside. Okay, so after you have made an access, you can push it into the biopsy needle and take a biopsy by creating a suction aspiration process. And then you can drill inside the same trocar. And then after you have drilled inside and reach into the vertebral body, then you create a cavity by using a balloon tamp, inflammable balloon tamp. And then after you have inflated the balloon tamp sufficiently, you removed it off and then you inject it using a special cannula. So these are the different equipments which you use for the procedure. Now, if you're only doing vertebroplasty, then you don't need this balloon tamps. However, if you are going for a augmentation procedure, including balloon kyphoplasty, then you will have to inflate it using an IBT. Now, there are two methods to approach. One is transpedicular approach. The other one is an extrapedicular approach. In a transpedicular approach, you have to be inside the pedicle. This is the safest one. By this, you are not going to injure any other surrounding structures. But what happens in the upper thoracic spine? This is good for T2 to L5, T10 to L5. But if you're going in the upper thoracic spine, then you see that the pedicles are located much more higher and they're much more angulated, isn't it? And that's why sometimes transpedicular approach may not be feasible in those conditions. So you will have to go for an extrapedicular approach. Now, in the transpedicular approach, the 5 points, the 5 landmarks, which I have discussed, I'm going to show it to you again. So this is in the true AP, this is in the true lateral. Okay. Now, in the true AP, in the C-arm, you can only have these two projections. This axial view has been put for your own consideration to understand we have a few nitty-gritties, which is very important for us to know as you go through the procedure. So in the transpedicular approach, in the AP projection, the first starting point when you are going for a level between T10 to L5 is you have to understand 3 o'clock and 9 o'clock position. Okay, so this is a 3 o'clock, this is a 9 o'clock position. However, if you're going in the upper thoracic level, since you have to angulate down, okay, you will go at 2 o'clock and 10 o'clock position. Okay, so if you see the pedicle as a round structure, then you can actually divide it into clock positions, isn't it? So 3 o'clock and 9 o'clock. In the upper thoracic level, above the level of D10, it will be 2 o'clock and 10 o'clock position. That's the first starting point. Now, this corresponds on the AP view as the lateral edge of the pedicle. Okay, that's number one. Now, that actually corroborates on the lateral view as the starting point of the pedicle. Then as you proceed inside, then you come to the midpoint of the pedicle. Okay, in the midpoint of the pedicle, will correspond to the midpoint of the pedicle in the lateral view. Now, a wire has been actually strung across the pedicle so as to make the things look more clear to you all. So this is a wire, a wire rod, a wire which has been tied across. And then as you go inside, the third anatomical position is the inside border of the pedicle. On AP view, you should never cross the inside border of the pedicle. Right? Why? Because inside border of the pedicle on a lateral view actually corroborates to the inner end of the pedicle. Okay, so by this measure, if in case you are going little bit anterior to the inner border of the pedicle, that means you have to be inside the vertebral body by now. Now the problem is that in the axial view, if you see, which is not visible to us on a C-arm, if you are not very careful, sometimes the pedicle may be very thin, isn't it? So by mistake, you may be thinking that I'm inside the pedicle, now I am going to be inside the vertebral body. You are actually going inside the central canal. So you should always confirm after reaching the point number 3 on AP view by changing the projection to the lateral view and then see whether your pedicle is in the midpoint of the pedicle. And this is very important. Unless until you have not confirmed with the lateral view, do not go to the point number 4 on an AP view. Okay. So point 1, 2, 3, I again repeat, point 1 is the outside border of the pedicle, point 2 is the midpoint of the pedicle, and point 3 is the inside border of the pedicle. Okay, these 3 views are okay with an AP view. Once you have achieved that, then you have to change the projection to the lateral view and then you move forward. Now in the lateral view, what you have to see is again the angulation of the needle, the trocar, the jump sheath needle, which you are pushing inside. And then you have to confirm that the trocar is in the midpoint between the two. And then the fourth point is when you are just in the halfway from the spinous process, that means you're already inside the vertebra. Now, in this step, when you have actually gone inside the vertebral body, then you can do the other procedures. Say, for example, taking a biopsy, I know, before you go in inside, and then you change the inner sheath, or rather inner a trocar, and then you actually can change it to a K wire, or rather a small a saw thing, which can actually push it your needle inside further. But then you do not cross the midline. You do not cross the midline. You stay here. And in the spinous process, you do not cross the spinous process. Now, when you're doing a vertebral kyphoplasty, a balloon kyphoplasty, then it is to be done on both the sides simultaneously. So that's why you do not want to touch the spinous process. You have to stay away from the spinous process on the AP view. Otherwise, whenever you are inflating the inflatable balloon tam, then those balloon tam will hit against each other. So when you are doing a balloon kyphoplasty, then you do not cross the midline, you just stay here. And then the 5 is again, this 5 is basically for if in case you are doing only a vertebroplasty. But then if you're doing a balloon kyphoplasty, then you stay away from the spinous process. Now, same thing which I just said about the extrapedicular approach. This is for the D5 to D10. And thank you. And in this, you actually start from, as I said, 2 o'clock or 10 o'clock position. So if you are standing on the right side of the patient, then it should be a 2 o'clock. If you're standing on the left side, it becomes a 10 o'clock position. And then the same way you go inside. But again, as you see in the thoracic spine, the pedicle is located very high up, to very close to the upper border, upper end place. So that's why the angulation has to be a little bit more steeper. But then try to keep your balloon tam in the center of the upper end plate and the lower end plate. Now, when you plan the trajectory, we have to keep this particular thing in the center of the two end plates. In fact, if there is a compressed colar fracture, you can stay a little bit on the upper part, but then try to in the center as much as possible. Now, inflatable balloon tam has to be approximately in the midway, as I've already said. Now, so this is how we start now. Now, on the AP view, we always start with an AP view first. So on the AP view, in the true AP view, we start from the outside of the pedicle. So on the cadaver, we'll show how it is to be done. So we use the Jamshidi needle tip to localize the pedicle, and then we can actually put a small incision by using a scalpel, and then through that we can go inside and feel the bone. As you feel the bone, you hold it with a pair of scissors, and then you can take a snapshot to find your good angulation point, and then you can proceed further inside. Now, in the AP view, as I said, you use the trocar to hit first of all, the outer border of the pedicle, take a snapshot on the X-ray, and then we go inside as we have discussed. Now, this has to be confirmed on the lateral view to see for the angulation, and then you can go in another two projections in the AP, in the midpoint of the pedicle, and then in the medial part of the pedicle. Now, if you have a 2 cm, or you're operating in a cath lab which has basically a 2 cm inside it, then you don't have to keep on changing the projections. But if in case you only have cm, I repeat, the first 3 steps, outer part of the pedicle, midpoint of the pedicle, and the inner part of the pedicle, should be done on an AP projection. And then you change the projection to the lateral view, and you have to go further on point number 4 and 5 under lateral view. So this is just the same thing which we have just discussed. Now, if you see, all these cannulas has marking onto it. Now, this marking will give you the idea of depth. Now, once you have gone inside the point number 3 and point number 4, and you want to go a little bit further, then what you do is you have another thing which can actually saw through the bone. You have this type of cannulas which can go inside the bone, and they have marking at 5 millimeter distance. So you do not go more than 2 to 3 millimeter inside further. Okay. So you can use this to rim inside the bone. And then once you are inside, then you can go with that balloon tam. So this is something which we have just discussed. So these are the 5 points which we have to be careful about. And then we can use this drills or biopsy bone biopsy devices. So we have to keep halfway between the vertebral body. So halfway, not only on from the top and the bottom, but also from the anterior and the posterior walls. And then once you are inside, then we confirm it on both AP and lateral view. And then we use the inflatable balloon tamp. So this is inflatable balloon tamp. This one. So it has basically two radio opaque markers, one in the tip and the one in the after the balloon. So once you are doing an X-ray, you can actually see these markers here. This is on the tip, this is on the back of the balloon. And once you inflate the balloon, the balloon has to be inflated to this point, the blue one. When you inflate the balloon has to be inflated with a contrast. So you fill it with a contrast in this particular pump. So you fill it with a contrast in this pump, and then this contrast has like markings for the mils, and then also for the pressure. So you have to check for both the mils how much volume you have injected and how much pressure you are creating inside. So usually we do not make a pressure more than 700 psi. It is too much. Usually the understanding is that for every 5 mils, the pressure increases by 50 psi. So usually in the balloon kyphoplasty, we can inject 5 mils of contrast inside, and that is the same amount which you're going to inject the cement inside. So if you have inflated the balloon by 5 mils, that is approximately 500 psi. That means you can inject 5 mils of bone cement inside. Okay. Now, once you are inflating the balloon inflation has to be seen in both AP and lateral view. So this is the AP projection. So you have to see that the inflatable balloon tamps have not crossed the midline. They are on their own spaces. And then once you are injecting, once you are inflating, you should also be aware of its upper border, because the bone cement, if in case leaks into the disc spaces, it can create discitis and other inflammatory pathologies. So we try not to be very close to the end plates. And then, as I said, you can actually look at both the balloon volume as well as the pressure, what you have created inside. And usually the bone expands in the area of the least resistance. So whenever there's a fracture, compressed collapse, that is a portion which actually expands much more earlier than the other portions. Now, so whenever we are increasing the contrast, the contrast inside the balloon tamp, it has to be increased in 0.5 cc's at each increment, and then we have to wait, take a projection, then the second inflation. So this contrast that we're injecting through the balloon tamp, again I repeat, will let you know how much volume of cement you're going to inject later. So that's why this is very important for us to understand both the volume and the pressure. So the end point of balloon tamp inflations are basically whenever you see on an X-ray that the fracture has been reduced, or the maximum pressure, that is 500 psi, for practical reasons. Even though the company says it can take a pressure up to 700 psi, it's better not to inflate more than that. The reason why I say so is that if you create more and it ruptures, then the contrast which you're injecting will create a passage for itself, and it can embolus. It can go into different other areas which you do not want to go inside. So try to be below 500 psi as much as possible, even though the company may say about 700 psi. And then the second thing is the maximum volume. So as I have discussed, 5 mils is the maximum volume which we give in balloon kyphoplasty. And then the cortical wall intactness is something which we need to consider. And as you see in this particular graph, which is a very ideal placement, the balloon has been inflated much more anteriorly than the posterior. So they always leave a space in the posterior element, so that by any chances, even if it ruptures or the cement extravasates, it should not go into the canal. Right? So the thing which we have to preserve is the canal. So we should be away from the posterior cortical element. Now, once you have done with it, then we remove the balloon tamp, and then we start mixing the bone cement. Now, the bone cement, they have made a special device in which you mix the liquid hydroxyapatite and the bone cement element inside it, and then you have to just rotate this chamber so it mixes the bone cement together, and then you can fill it inside one of these cannula. Now, these cannulas are for filling inside the bone cement. Now, this has a tap and a tube or a sheath. So you attach it here, and then you fill it with the cement inside. Now, This also comes with an increment. They have a 5 millimeter increment onto it. So as you go inside, you go by 5 millimeter increment inside, so that all the cement which you have collected in this tube can be injected without any extra excessive pressure inside the cavity which you have created with a bone, with a inflatable balloon tap. Okay, so you can inject it. So usually this 5 millimeter increment corresponds to 0.5 mils. So you may have to take 3 or 4 times the bone cement from this chamber to this tube, and then you can fill it. So once you are done with the filling, again take a snapshot and see whether all the cement remains inside the bone and it has not extravasated anywhere else. So in this particular stage, again you have to take both AP view and lateral view to have a complete understanding as to where your cement is going. Now, always whenever you are finished with the bone cement, take the whole thing out. Do not take the tamp out and then remove the sheet later. Why? Because it can leave a trail of cement behind. Right? And then that particular cement, if in case remains inside the soft tissue, can be a little bit of problem later on. This foreign body element can be there. So try to remove the whole sheet completely in a one piece. Now, there are definitely certain complications, even though they have been reported to be very low these days as compared to when they first started. The first and the foremost is cement extravasation, which can lead to cardiac arrest and myocardial infarction, cardiac embolism, cerebrovascular accidents, and pulmonary embolism. So these should always be in your consent sheet to the patient, because even though they're very low, they has happened to somebody. So if somebody has suffered this problem, then it can happen to you also, isn't it? So that's why it should be on your consent paper. Fat embolism is something which is we all know about. And then adjacent vertebral body fractures, particularly in the osteoporotic spine, is also seen to a tune of 3 to 25%. So we have to be very much aware of these things. And then there are certain things which are very specific to balloon kyphoplasty, like cortical fractures. When you're expanding the balloon, by the force of it also, you can create more cortical fractures. Then recollapse after deflating the balloon can occur. So whenever you deflate the balloon, always take a projection to see that you have maintained that particular height which you have gained after balloon kyphoplasty. And the balloon rupture can occur. If the balloon ruptures, do not panic. You can actually take it out, take some snapshots, see if the contrast is not going anywhere else or not, and then use another balloon to inflate it. And then transient hyperalgesia can remain because of the various neural elements which has been irritated because of these contents. So in a nutshell, so in a nutshell, the whole procedure is about, first of all, finding the correct orientation on both AP and lateral view. And then your needle position should follow those 5 anatomical landmarks, which we just said. And then after your needle is inside the cavity, you inflate it by using an inflatable balloon tamp. And then you prepare the bone cement and then push the bone cement inside the cavity, which is already created in balloon kyphoplasty. So these days we are all professing for balloon kyphoplasty rather than just an augmentation vertebroplasty, because it helps a lot and the complication is much more lesser. And then you always confirm your correct placement by taking a projection in both AP and lateral view after the procedure. So with this, we come to an end on this presentation, and we can move to the cadaver lab. The problem is that we had actually tried to got 3 C-arms, but we could only get 1 C-arm at present. So what we do is we can actually change places, and 2 people can work at the same time on the cadaver. So one on the right, the other one on the left, right? So we can use those trocars. First of all, try to feel the trocar as it goes to the bone. First, take only AP projections for these first 3 anatomical landmarks, 1, 2, and 3. Outer part of the pedicle, midpoint of the pedicle, and the inner wall of the pedicle, and then change the projection to lateral view. And then both of you on either side can actually go into point number 4 and 5. And then you inflate the balloon by using the contrast. Right? That will give you a sense as to how it goes ahead. And then we will change the hands, and then the other person can start with the other level. So the first person, the first group, the first 2 will start at the level of D12, then L1, L2, L3, 4, and 5. So that is how we can go ahead. So we will use only table 1 for this purpose, and we will try to finish this vertebrokyphoplasty by 10 o'clock. Any questions regarding the presentation or anything, how we want to do the things inside? Okay, just few housekeeping announcements. We have got all those disposable gowns here. So it's better to change your aprons, your coats. You can actually hang your coats in the provided stands and then put on those gowns. Leave all your accessories or personal items inside this room. Do not carry your phone inside because those are cadavers. They may actually get your things can get soiled up. And since we have lead aprons there, only people who are putting on the lead apron stays inside when the X-rays is on. So one of the volunteer will shout the projections around. So whenever the CM is active, so be careful, come outside the room. Do not get yourself exposed too often. And then once before we touch the cadaver, please, there's some incense stick there, light some incense stick. And once we are done with the cadaver workshop, please do pay some respect to the cadavers. And that's the thing to go ahead with. Krishna, anything, sir? Yeah, it's a DNA with hydroxypropyl. Yes. It has. So that's why you can actually see the bone cement filling up later once you are done with the procedure. But then rather than filling the inflatable balloon tank with air only, which will not allow you to see how the balloon is actually inflating inside the bone, it is advisable to fill this particular pump with the contrast and then rotate it. The demonstration is for the X-rays are all vertebroplasty. No, they were for the balloon kyphoplasty. Only thing is that in the demonstration purpose, material, they have not kept the patient with a wedge compression collapse fracture. I was looking for those videos in case, but then I didn't find it. But then the procedure is for the balloon kyphoplasty. For the vertebroplasty, we don't need an inflatable balloon pump. We will just push in bone cement under the high pressure. Do we make any cavity or something like that? In the vertebroplasty, no cavity is made, but in the balloon kyphoplasty, the cavity is made and then the cement is placed, and that's why it is much more safer. So it is advisable these days to do away with a procedure called vertebroplasty and do only balloon kyphoplasty. Those are good questions, Hazard. Okay, so we go to their place for the demonstration. Archis will be going for the demonstration now. We will again join at 10 o'clock.
Okay, sir.
Okay, I'm stopping the presentation for now.
We are going to have a small workshop today on UB. What is UB? UB is unilateral biportal endoscopy. Now, unilateral means one-sided. Biportal means using two ports. Endoscopy, the word explains itself to you. It is a wonderful form of spine surgery because it has it has a very long and an extended range. You may feel the learning curve is a little difficult, but believe me, it isn't. It needs patience, calmness, peace of mind, not getting irritated. That's all it needs. Now I'm going to play some small presentations. I'm going to play first a small video of a cervical discectomy that I have done. And the whole idea is that,
a small video on how do I do it. Expose the lamina, expose the spinal lamina junction, come laterally onto the facet joint.
That side is the spinal lamina junction. Now we are coming laterally onto the facet joint.
Step 2, identify the V junction, identify the SAP.
What did I do? I just wanted to pause it.
Should I get you the bone saw model?
No, I just want to pause the video. Okay, I'll just play it again. Sorry.
A small video on how do I do it. Expose the lamina, expose the spinal lamina junction, come laterally onto the facet joint.
Now we are sweeping towards our side. We have exposed the superior lamina.
Step 2.
And we are coming to the V junction.
Identify the V junction.
All of you know the V junction in a cervical AP X-ray, where the superior and inferior lamina meet each other. Why is the V junction so an important landmark? Because that landmark defines the lateralmost border of the myelin. The cervical cord does not extend beyond the V junction. At the V junction and beyond the V junction is the territory of the lateral mass made of the IAP and the SAP. And that is exactly where your root is exiting. Now, if I want to do a motion preserving surgery, as neurosurgeons, you all have all learned, and orthopedic surgeons, that ACDF is the gold standard. And believe me, it was the gold standard. I always agree with the fact that it was the gold standard. But today we see adjacent disc disease. We see patients with one cervical TDR going on to needing a second. And if he's young, he lands up having 4 cervical TDRs. A miserable lifetime. Extension of plating, extension of ACDF. These are not the solutions. The solutions are disc preservation surgeries. So that is where, or motion preservation surgeries rather. So that is where I developed cervical UB, and I also do cervical anterior endoscopic discectomy. Through a 4 millimeter scope, I remove a central fragment. I know I create a track, but in a 16 or a 17 millimeter wide disc, if I'm creating a 4 millimeter track to target and remove a fragment, I am preserving more than 80% of the disc and nucleus. And patient is pain-free, going home the same day. So now what you see here is the V junction. What is the V junction? I have, this is the superior lamina, this is the inferior lamina, this is the flavum, and a little bit of tagging tissue over here, which is from the deep fissure of the cervical spine. Okay. Now I'll play this video a little further and we'll go step by step.
The SAP and the IAP, where they meet,
this is the IAP,
and identify
this
the
is
laminas. We are right now at the V junction. Stripping away some tissue, exposing the flavum.
The fluid has gone away, so there's a small drop of blood flowing in.
Confirm your position on a C-arm.
Now we start flushing. You can see it's a relatively bloodless field.
And start burring away the lamina, the facet joint.
Now you see, this is the IAP part. The IAP is sitting on top of the SAP partially. As I burr away the IAP, you can see the facetal cartilage and you can see also the SAP coming up below it. And it is that SAP which is below the IAP that I need to burr thin out if I'm going to expose my root. So I'm going to play it further.
Return up to a lateral extent.
You can see the cartilage
that you wish to go.
You can see the SAP now.
Below you can see that we are burring away and thinning away the SAP. Proximally we were cutting away the IAP. Identify the edge of the SAP towards the canal. Strip away the tissues. And with a very small 1 millimeter kerosene, start the process of decompression. As you come laterally, you will see the dural edge
the cord is here,
and the bulging disc
under the flavum.
In the axilla.
You can see the disc bulge. You can see the traversing root.
The traversing root and the bulge of the disc is clearly visible at this early stage of decompression itself.
Now I'm cutting the pedicle. I'm cutting the pedicle, going out on the SAP, cutting the pedicle. The traverse exiting root is here. I'm just going to bite below this little capsular structure.
Identifying the exiting root, delineating the axilla completely is essential to starting the decompression of the disc. As you can see now, the exiting root, the traversing root, both are open. Removal of the fragment from the axilla. Using a small grasper.
It's a 2 millimeter grasper. So you can imagine how big the screen is and the magnification is. This is the cut pedicle. This is the exiting root from here. This is the traversing root. I'm in the axilla. As I decompress this axilla and the fragment comes out, this whole axilla will come and rest here. This whole axilla will shift here. Please see the comparison at the end of the surgery. Right now, the disc has pushed this exiting root and crushed it against the superior pedicle. There's a 1
And
millimeter.
now teasing out the main fragment.
I feel breathless when I see it even now. So you can imagine how I must have been feeling on the table. Out comes the fragment. And now,
You can now see the complete root as it
is
sweeps
axilla?
out through the
There's no
foramen.
axilla. I've opened up the
Nicely
cervical pylon
decompressed.
also.
Little laminectomy and a little phlebectomy towards the midline cord. Decompressing the entire cervical canal. Introducing a drain.
This is your pedicle.
So that I
This is your
prevent an
exiting
epidural
root.
hematoma
You
formation.
can see the end of the pedicle
You
also.
can see the root sweeping around the pedicle and exiting the foramen. I thank you very much for your patience and kindness. Thank you.
How do I get out of this, please, sir?
Escape.
Okay, I'll just press escape. So I just wanted to show you this brief video for you to realize what UB is all about. Now I'm going to play another very basic video about an introduction to UB. Okay. And we'll start playing from here. Yeah. Now, what is UB? UB is an under irrigation surgery. Sorry, sir. Yeah, can you please help me with this? It's basically an under irrigation surgery with a wide access to both sides of the neural tube. You can actually play football on both sides of the neural tube. And I'll show it to you. I'm not just making an empty talk. By the time these lectures are over, you will realize the potential of what all UB can do. Now, what do? I use a simple arthroscope. Many people tell me, sir, but an arthroscope costs 3 lakhs. I say, no, buy a Chinese one, it costs 20,000. I mean, in Indian rupees, so I don't know the Nepali conversion, but it's not really very expensive. When we look at medical equipment, most of you from the neurosurgical community will already be having a burr machine because you'll need to make holes. Then comes the use of a radio frequency or a plasma. We don't use the normal bipolar because the normal bipolar produces a very high temperature. And if you touch near this cord, it actually shrinks the cord, the dura. But a plasma is a capping of the of the radio frequency probe. And it keeps the temperatures less than 80 degrees. So, you know, the water that is flowing on your hands during UV, you will feel slightly warm. And at low power, at 1 and 2 power setting, you can actually walk on the dura, pick up each vessel and coagulate it so as to have a perfect hemostasis, the way you would want it or desire it. We use normal spine instruments. I am a little spoiled, so I like to have my rotary Keresins, but you can use your normal spine set. You can use a normal dural retractor. You can use your normal dissectors, Penfields. So the requirement for specialized tools is less. You need not buy a very high definition TV like, Stars Image 1. You can have something simple. You can have simple ones. They are all available everywhere. You can have one which is non-HD also. So vision is just your comfort zone and how you develop it. But the bottom line is it's not expensive. As you can see here in my hand, there is a scope, a camera, and there is a plasma wand in my hand for the initial space making. Now we'll go to the next slide and we'll come to that, son. We'll come to that, son. There is an excellent view due to magnification. You saw the magnification and you saw what my 2 millimeter punch looked. It looked like a big elephant in a room. So your accuracy is tremendous. Visualization is tremendous. You can see both the roots, 4 roots if you wish to. You can access the disc from your side, contralateral side if you wish to. You can relieve, sorry, wrong spelling there, central as well as lateral canal stenosis if you wish to. Facetal cysts can be dealt with. So all posterior pathology, even anterior. When I do UBT, if my scope is resting in the disc space, I am curating the disc space from inside. I can see across. I can go up till the contra root and decompress. What is the major one complication that we have in TLIF? Whenever we bang in a TLIF cage, sometimes patient wakes up with severe pain in the opposite leg. Why? Because you cannot do adequate decompression. If you are using MIS TLIF or you're using tubes, you cannot go over the top to do opposite side decompressions. Where here I can walk across the entire spinal disc between 2 bones, clear out everything I wish to. Why? Because my scope is inside the disc. Now, these are the kind of advantages of direct as well as indirect decompression that is merged in UBE. It's an easy option in L5-S1 discs with high crests and migrations. That is, in a world of endoscopy, there's always a fight. Can transforaminal guys do L5-S1? I do it very comfortably. So it does not matter to me, but to many other surgeons, it is difficult to manage an obliquity of the L5-S1, and therefore they prefer to do the birth of interlaminer came from this. Let's put it this way. So it's one of the relative indications, I can say. Now, I'm pausing this to show you what I mean by a free hand and what I mean by a restricted hand. We all use Medtronic tubes. We all use the EasyGo system. Many of you may be using Indian Pitker tubes. What does a tube do? It channelizes, it focuses you on a spot, yes. But does it give you free hand movement? That's why I use that word. I can play football on both sides of the neural tube, which you can't. How many times are you going to keep on adjusting the tube? Especially in a bloody field. You get frustrated. Most of you will end up opening up your patients after that. So UBE gives you that two free hand movements. Obviously, you need to develop ambidextrous skills because when you're standing on the right side of the patient, the scope hand shifts, the instrument hand shifts, or you can do across the top UBE. So there are many options in that. We won't go into those nitty-gritties right now in a basic workshop. But the basic comparison of between the two systems is open. Now, answering sir's question also, and at the same time trying to show you, okay, what do we do? So we keep close to the midline if we wish to do a central decompression. The scope is docked at the lower edge of the superior lamina. The walking, or I call it the walking, some people call it the working, because the portal walks actually, is on the superior edge of the inferior lamina. So basically 2 millimeters above the disc, 2 millimeters below the disc. You can use a semitubular retractor if you wish to have if you feel that the fluid is not flowing adequately. But if the fluid is flowing adequately, you don't require an assistant's hand, and water just, if you've created good channels, the water just flows out very easily. So water does not go anywhere else but in and out. Okay, because that is also a relevant question. Okay, where does the water go? Now, the key to this is triangulation. I need to see that two instruments are meeting at a depth. Not difficult if you have a thin patient. Somebody who's really thin in this room, I can't really make out, but then comes the medium type, that is Bal Gopal with a little pot belly. And then comes me, huge guy. Okay. So the deeper it is, yes, triangulation is a little difficult, but for that we have a very simple system. When I do my triangulation, when I teach my boys triangulation, I tell them you put in the working port a little bigger, put in a big dilator there, and then you triangulate the smaller scopic portal along it. It just slides and triangulates. So the big talk about triangulation is difficult is all nonsense. It's utter nonsense. You can easily triangulate. Okay. As long as your pathways, as long as your channels are well made. And that I will be showing you, explaining to you how it is done. Now, you must understand that the difference between any scopy, even your skull-based scopy for neurosurgeons and for orthopedic surgeons, I really don't know the distribution today, but in the knee or in the shoulder, there's a lot of space. Even in your skull base, you have some air cells and some space. But in the spine, you have no space. You need to create the space. So how do I create the space? When I triangulate and I move the two together, I create a channel between the two triangulating points. Like how in spine we use a COBS. Do you know we use a COB to lift the muscle? Same way I use the dilator to shift the muscles. Strip and shift the muscles. Okay. So once the muscles are stripped, everything is nicely opened and we are comfortable. That is the time we start our surgery. Now, how do I keep the muscle up from the lamina? I keep a certain fluid pressure. 30 mm Hg is what is recommended, but I use 100, 120, 160, whatever I need as long as I've not opened the dura. As long as the flavum is intact, pressure doesn't go onto the cord. The moment the flavum is open, you have to drop pressure. You have to come down to 30. You do not want to create a paracorda kind of situation in a patient because of extrinsic pressure. Lumbar spine is forgiving, but cervical spine is very unforgiving. So that is the bottom line of creation of space. Please see this video. See how triangulated. I'm doing like the dance with the chopsticks. See, I'm going front and back, front and back. Thank you. Yes. Now the purpose of this is the scope is always going to be behind the working instrument.
Excuse me, sir.
Yeah.
Can you just interrupt for a while? Our
Sure.
principal is here. Let me
Please,
invite
please,
him and
please,
introduce
please,
to the crowd. So our principal, sir, Professor Ravindranath is here.
Welcome.
Presently is from Mumbai. He's our faculty invited. And we have already started. The first part of the workshop is over. The second part is this presentation on endoscope.
So, once again, good morning, everybody.
Thank you, sir.
Yeah, thanks, I welcome you.
Thank you, sir.
All participants. I wish you success for this also.
Thank you.
And I hope you will continue in the future also. If any help is needed from our side, please let us know. So, please also, sir.
No, sir, we would like to thank you for the workshop and thank you particularly to Dr. Dinesh who provided us the cadavers for the workshop. So thank you once again. And we'll see you again in the evening for the inaugural function. Please try to see it again.
Okay, have a good day.
Thank you, sir.
Thank you.
Now, this part I'm going to skip in this talk because I'll be taking it in another video, which is a much better quality video. So I'll shut this. What did I do now?
No, it's okay.
I need the next video, which is steps. So now, what are the steps that we undertake when we do a UB? There are certain basic steps, and you have to understand certain basic steps and certain basic anatomy. You see I'll hold this in my hand to show you that the laminar edge is not an edge, it's a laminar wall. You need to clear tissue from the upper edge, the middle wall, and come to the lower edge, especially near the superior lamina, because the ligamentum flavum goes below and attaches to the lamina. At the lower lamina, at the superior edge of the lower lamina, supposing we are talking of L4-5, at L5, the flavum splits into two and grabs both edges of the lamina. But when you come up, and please, this is very important to you because now you're going to see things in a very different way, the way you've never seen it as an open spine surgeon. You just assume things, and those assumptions don't work here. So this is why this talk is very important. So I'm going to now show you the spinolaminar junction, which is the inverted U, because now I'm going to see the spinous process base from below. I'm not seeing it from top, I'm seeing from underneath. I'm going to detach a little bit of the interlaminar ligament, 1 or 2 millimeters. See across the entire base. Now, the entire base is also going to be broader. Scopically, it is going to be broader. The entire edge of the lamina is also going to be broadened like a wall. Now, that appreciation is very important if you want to understand UB anatomy or scopic anatomy. Let's put it that way. It's more simple to talk that way.
Good evening, friends. We are seeing a video of how do I do it series. Now, what are we doing here? We are using a plasma wand, which is using both coagulation and
I
ablation
can see
modes.
that I've opened up
And
the
we are
laminar
landing
edge,
on the lamina,
creating
creating
some
some
more
space, controlling bleeding that is coming from
This is
soft
all
tissues
the
that we've
connective
aggregated our
tissue which
organs.
is between the
And we are
multifidus,
identifying the
the
spinal
rotators,
lamina.
and the lamina.
Right now, I'm clearing tissue from the cranial lamina. And as I clear further, I'm going up and I'm going up to the base of the spinous process. As you can see, this is the inverted U, which is our starting point.
Now I'm going up on the base of the spinous process, climbing up.
There is a bleeder which is
Sorry,
losing,
there's
so
a
we
bleeder,
are
so we have to
tracking
correct
our
it.
stroke backwards and then using the coagulation.
We
mode.
come across 3 arteries, mainly
control the
superior, middle, and inferior fascicle
Now I'm
arteries.
stripping the high crest, the upper edge of the lamina.
This is
and
the upper edge
stripping
of the
away some
lamina.
of
I'm
the
stripping.
extra flaval tissues.
Now
which
see how
come
I'm
in our
stripping
way.
the flaval tissues in between the
As you
extra
can see,
flaval tissues. This is the
In
base.
the upward
Can you see how
stroke,
thick
I
the
am
base is?
exposing the base of the spinous process.
It's like a roof.
The tissues on the outer surface of the spinous
With our big
process.
keratins, we don't
And
realize.
now
We
you can
just
see,
brush it
actually, I'm
carefully.
going towards the tip of the spinous
With
process.
endoscopy, it becomes a
Okay.
big source of bone
Now
graft
from here,
also,
I'm
infusion.
going to climb up a little.
See,
From
I'm going
below,
up on the base.
upwards onto the spinous process. I'm separating away the ligament over there. And I'm freeing up the entire base of the spinous process because it's quite broad, it's quite flat. Now, when we do this, we are establishing our first 2 arcs of surgery. The first arc of surgery is the dissection towards our side,
I'll jump
right
a little
on the
between them.
IAP until the
Now
IAP
see,
ends.
I'm
and
stripping the
SAP
inner edge
starts.
of the superior lamina, and
Because
now
as
you
the
start
SAP
seeing the
is tracked
flavor.
further, you will come up onto the lower laminar surface. In this case, we need to do contralateral
Now I'm burning away
sublaminar
the
decompression.
base of the spinous process.
And opposite side,
This is a decompression surgery, not a fusion surgery.
ICELF.
So there's no need for me to harvest bone graft, rather I harvest graft from here. I'm just burning away the entire spinous process base.
Simply put,
Because if I have
side,
to go
contralateral
contralateral,
SAP
that is one
osteotomy.
structure which is going to come in my path.
This is the opposite side, muscular tissue which is bleeding. We have cut through the entire base of the spinous process, gone onto the opposite side, but we have not cleared our arc adequately. So now I'm clearing our arc. The base of the spinous process is very important to be cut because your drilling instrument and your kerison, if it has to go contralaterally, the major obstacle to the smooth over the top passage of the instrument will come from the base of the spinous process. You can see how much of the spinous process we are exposing, and we are cutting right at its base.
Because I want to go over the top, I want to go to the opposite lamina, and I want to go to the opposite foramen, opposite exiting foramen. So that means opposite superior pedicle, and just below that pedicle I want to go, and I want to see the root exiting from there. That means I have to cut significant amount of laminotomy on the other side, but I don't do a vertical laminotomy, I do a sublaminar decompression. So I'm making the laminar thinner and thinner until I reach the opposite side. And that is what you're going to see now.
This spurring allows me to go across the midline onto the contrast surface. And now I'm merging the two arcs of movement. That was the laminar arc of movement and the spinous process base. At the same time, control the blood loss of the patient. Alternatively, one can definitely use
side.
bone wax.
Now, neurosurgeons like to use bone wax.
Many neurosurgical friends of mine.
But you find that in the brain, if you re-explore the brain after 10
exposing
years.
Some more of the base of the spinous process.
I prefer not to use
some
wax
more
in
of
the
the
spine. I
laminar
prefer
base,
to control
some
with the
more
good
tissue on
plasma.
our side.
And you can see here the opening up of the midline. The midline cleft is being seen. The phlegm superiorly in the midline has a cleft. That cleft is a very important landmark in UB if you want to know where am I vis-a-vis my contralateral decompression. Now I'm exposing some more tissue on my side so that I get across the field vision. At the same time, controlling all bleeders is very important.
Once the bubbling of our.
So this is that little part of it. Now you can start seeing our side of the facet joint, IAP in its entirety.
Targeted disc and decompression is
The central midline cleft, you can see the phlegm on the opposite side, you can see.
Now I'm going towards the midline, the base of the spinous process. Our side of the base.
So the stage is set for the
and we will
complete decompression to occur now. Now, all this while we are extra flavorly. You can use whatever fluid pressure you wish to use because you're not exposed to dura. There's no dural pressure. The phlegm is hard, rigid, it bounces off all your fluid pressure. Okay, so this is the midline cleft.
We are now probing carefully.
Now I'm using my burr to grab the base over there just above the midline cleft
scenarios.
And creating a track so that I can go nicely contour on the opposite side.
Because here I expect the midline cleft now open up.
Now I'm going opposite.
The tight stenotic.
It's a very tight stenotic situation here.
Place sometimes
there's a diameter burr, and see how I'm catching the lower edge of that lamina.
Level cleft, midline cleft tends to pop out. So one must be very careful. Respect the top across to the upper side.
Now I'm on the opposite
and
side.
Here I'm cutting the lamina under surface on the opposite side with a diamond tip burr.
And the facet joint.
Very safely coming towards the midline and then again sweeping towards the opposite.
This is decompression of the opposite lateral facet.
So I'm cutting in the third arc. The third arc starts from the base of the spinous process. You cut underneath the lamina on the opposite side and you undercut the opposite lateral canal on the opposite facial surface.
If you can see, I'm
this
across.
Is the third arc of your preparation. If you wish to do a complete phlebectomy and a decompression, of a tight stenotic canal. This is not necessary to be done when you have to go ahead with an ipsilateral disc surgery, where only ipsilateral flavectomy or a targeted flavectomy to directly land at the herniated fragment is to be carried out. Here we are dealing with the case of severe stenosis and we are decompressing.
I'm coming
Right
towards
now, the
midline.
opposite side, coming close to the midline, crossing the midline, coming back to our side also, and creating space all around. You can see how thick and big the opposite lamina is, how difficult it is. And you can see also the angle of our bone. Please see the angle of our burn. It is coming in from what direction? Almost 2 o'clock.
We're
And
coming
where
like
is it
this
going?
and we're going upwards.
It's going almost to.
This is a horizontal view. I'm seeing
That
underneath
means
the cut
the lower
lamina.
scopic
I've gone to the
portal
lateral recess on
is
the
now
opposite
in
side,
an
but the
oblique
flavum is
trajectory
still
going
intact.
across the midline towards the opposite pedicle. Why? Because I want to decompress the opposite
Now see,
foramen.
with my
As you can
probe,
see,
I'm
I'm
not even
just
running
gently
my
pushing.
probe.
I'm not even rotating the burr. As
Just
I'm using the
pushing.
burr like a stripping or a grinding surface, I'm able to expose more and more of the tissue, remaining extra flavorly, nicely protected by my sleeve and sheath. And at the same time, exposing more and more of the undercut sublaminar decompression, which I'm carrying out on the opposite side. And that is the lateral recess side. This is the where the IAP is sweeping downwards.
This is the sweep
The
of the
minus
IAP on
turning
the
into the
opposite
IAP.
side going towards the opposite facet.
Now I'm again cutting towards the laminar surface. You can see how deep we are going without decompression. Now this is we are decompressing the lateral surface, where the lateral recess
The
is.
lateral recess, I'm removing
And
the
the
IAP.
tissues are automatically stripping
And you
away.
can see the SAP is coming up over
You can
here
see how
now.
the lateral recess is getting exposed and getting burred away.
See the last edge of the lateral recess. So I've flattened out the lateral recess completely. I'll be flush to the pedicle on the opposite side. So I've not caused any instability. You never cross the opposite medial pedicular
A
wall.
good use of the burr can take you to the opposite foramen very
Now,
safely and
we are
very
going to go
easily.
towards the opposite foramen
Strip,
slowly.
keeping the flavum between you and the neural structures. But at the same time, try and create space overhead so as to not press down too hard on the neural
I
structures.
am barely touching the
There's a nice and thick
flavum below
lamina,
here.
and I can definitely do
So
a
I'm
lot
not
of
causing any
undercutting of this
extensive
lamina
pressure.
of the spinous
I've
process
cut the
space
lamina so much to
to
create
create
space to go on the
and then
opposite side.
adequate space,
See?
more
Can you
than
see this is
adequate
the pedicular wall there.
for our decompression to be perfect.
So that means I'm cut perfectly till the opposite pedicle. Complete decompression of the
And
lateral
though I have
recess,
cut it in
flush.
troughs, I'm now trying to burr it and make it into one uniform surface. And creating lots of adequate space for working on the contour side without really pressing down upon the dural structures, which are below the flavum.
You can see now our
As you can see,
flavum
there's hardly
basically
any
ending
pressure.
here. There's a little flavum
The
left.
space has been
There's a little
created
bone
above.
left here.
Here I'm working on the lateral
Now
recess
this
side.
side will start the
I'm
SAP.
almost gone down to the opposite pedicle.
Opposite pedicle, opposite SAP is from that side.
The lateral
The
recess.
inferior.
And I'm burring away, creating space both ways.
Why important for me? Because
This
I intend
helps
to
me now
decompress that
complete
exiting route also.
the third arc of decompression. What is the fourth arc, friends? The fourth arc is when you identify the lower lamina, superior edge of the lower lamina, and you cut across it in a complete U to meet this cut on the opposite side and your facetal cut on your side. So with that, I think our little tutorial for today of how do I decompress is coming to an end. Here I find again the base of the spinous process troubling me, irritating me, not allowing me to work properly. So again, I've come back on my side. I've come back on our side of the spinous process, and I'm detaching some more of it from below and across, so that, like I explained to you before, an instrument which is traversing in a caudocranial direction towards the opposite foramen can do so with great comfort, high angle, not pressurizing the neural structures below, and do a beautiful, adequate decompression. You almost reached the opposite
nice
pedicle.
flush the whole wall is.
The opposite lateral
This
recess
is opposite pedicle.
completely
I'm poking
exposed,
the bone. That is the SAP here.
and we are just across. We are literally across the entire neural structures. You can see how the high my angle is and how low I'm reaching into the SAP now to cut the SAP.
Now I'm going towards the opposite foramen.
This is a beautiful way to do decompression because you are completely extra flexible and highly protected.
Just a
Once we
little more.
complete with the phlebectomy.
I will go to the end. Now I've gone towards the opposite foramen.
Sometimes the distal vision gives a better vision as to the
And
amount of,
you can just jump a little more.
and thinned it out.
And you can see now, this is the center. Yeah.
It was not changed, only the
Now
camera
see,
is changed.
I
That
was
is the
probing the opposite
foramen which
foramen. That is the superior pedicle and its IAP edge.
and you can see
There is
how
a
deep and across
flavum
we have
going
gone.
across out, covering the exiting nerve root.
this
And
is
I'm going
undercutting
outside the
of
foramen. I'm catching its edge, and I'm
surface.
expanding the edge of the IAP part. The SAP is down here, which I will be osteotomizing later. That is not part of this video because there are other videos on it. But you can see the SAP here. You can see the IAP here. And you can see now I've taken a top view. I'm showing you that my cord is here. And I have exposed and created so much space on the opposite side. I will show you one more last video before we go and start our work. So just have to get out escape now.
Escape. So before we go to the other video, can you just repeat the 4 arcs which you mentioned during the video?
Okay, teacher, we'll go through that.
The one.
Yeah, I need a pointer or something. When somebody, something. Just, or you can just show it there. Yeah. Now what happens is, I prefer to see my imagery. In the form of arcs. Now, what are my arcs of visualization? My first arc of visualization is my lamina. This is the U junction. This is the spinal lamina U. This is the U spot. That is always the initial targeting point in any endoscopic posterior procedure. That is where I must land. That is where I must triangulate, and that is where I must start identifying the issues between the lamina and in the interlaminar gap. So I land there, I identify the first arc. The first arc of movement is to come from this spinal laminar junction and then come down and find out the IAP, the crest of the IAP, where the IAP turns. The turn of the IAP is very important. Finding out this lower joint is important. Because from there, if you push down, then you are going to climb up on the SAP and the superior lamina, superior edge of the inferior lamina. Followed? So that forms the first arc. First arc is base of spinous process, coming right down and sweeping down till where the IAP curves round. I stop there. That is the first arc of visualization. Now, the second arc of visualization. Now, when I want to do only my ipsilateral discectomy, I don't need anything else. Having done that, I just need to go in the interlaminar tissues, remove those tissues along the wall, superior crest, middle part of the wall, and expose the flavum. Why? Because the flavum is going below the lamina. It's not coming on the lamina. So until I reach the flavum, I'm very safe. There is no way that I can touch the dura with my wand. Clear? So that is enough for a simple disc surgery. But now I want to do decompression. So for doing decompression, going right on the opposite side, my dear friend, I will need to cross this base. I will need to cross. Now here it's vertical and big, but in reality it is narrow and tight. If I need to cross from here, I need to cut this base. So that is the second arc of movement. I identify the base of the spinous process, go up, detach a little bit of the interlaminar ligament. So I know, okay, now this is where it is now. If I want to do bone grafting, if I want to do a fusion, I remove a lot of that base with the kerison or with a but here there is only case of decompression. So if there is only decompression, it's easier to burn rather than chip. Okay? So that is the second arc of movement. Now that arc of movement allows me to see across. So then what will be the third arc? Obviously, logically, the third arc is going to be the opposite lamina going to the opposite SIP. Now, when I have completed that, I have completed the superior part of the entire exposure. Now, what is left? The fourth arc. The fourth arc is what? From where my IAP ends, the superior edge of the inferior lamina starts. And that goes and meets the opposite IAP. That becomes the fourth arc. So it's like in how we say in Hindi, chaukat baithana. So it's like I want to play basketball and I want to know what is my basketball court. No? When you see cricket, IPL, or we see some whatever, we see the stadium is big, but there is a ring of white ring around, and the ball goes out, then it's a 6 or a 4. The same way, if I'm going to do a decompression, I need to know where all I'm going to go. So I need a clean arc of movement in all directions. So therefore, you need to set these 4 arcs of movement. These are the arcs of movement. Now, why they are important? Because with each arc, you will realize your instrument flow and handling changes a little. So this is how we develop the arcs of movement. Now, what are the principal landmarks? The inverted U, arc lamina, coming to the IAP, cutting the base, seeing the midline cleft. From the midline cleft, starting to burn underneath the lamina, creating space because the flavum goes 5 millimeters in and attaches. So I have 5 millimeters of bone which I can peacefully cut and realize, okay, now this is my inferior edge that is climbing up onto the flavum. Now, as I go laterally, the flavum is also going lateral. So I can keep on following that flaval edge until I reach the opposite flavum. And that same flavum is then going outside the foramen for almost maybe 1.5 centimeters, covering the exiting nerve root. So if I'll show you a video of the para UB later on, all are not tired, you will realize that the flavum is your best friend. Follow the flavum, you can't go wrong. Preserve the flavum, you can't have major complications. Okay? The flavum allows me to use higher fluid pressures. It allows me to do bone burning, cutting, chopping, burning, peace of mind. I know accidentally also some instrument slips. Thick flavum there, nothing is going to happen. The moment I detach the flavum, when I have a pulsating vena there, then I have to be very careful. So that is where I'm the pioneer of this technique of extra flaval decompression contralateral. Where I pioneered this technique to the point that I can even do the osteotomy. That I didn't want to, because I just wanted to show you an introductory video. So that is not there. In the other videos will show you how we do it. Okay. Plus on my YouTube also, there's all these things are there. Now I'm going to show you the next talk. The next talk is regarding inflammatory burr foraminotomy. So we play this. Okay. When you are unable to use an osteotomy is a very thickened superior articular process. Now, superior articular process, we have a concept. It's a very small structure. It's like a small tip. No, sir, it's not. What you see is not that. The superior articular process is a huge structure. It's a huge structure in which your IAP sits. It extends inwards, it extends upwards, and it is out in the foramen. Sometimes it is so big that it becomes impossible even for me to osteotomize it. I have to osteotomize it in chips, or I have to use a burr to thin it out before I cut it. So this is that little talk, and we are going to go through with it. Now here you can see there's a pulsating dura below me. I've opened the opposite foramen. There is a flavum extending there, nerve root there. I'm trying to use an curette to cut into that bone, but it's so hard that even a curette is failing. I have taken multiple cuts in that bone. There are multiple vertical cuts in that bone, if you see carefully. But the SAP is just not cutting. So what am I to do? I am taking a burr now and I'm going out in the foramen, burring, trying to make it as thin as possible so that I can finally remove it. Now I'm at the foraminal edge. I'm at the edge of the foramen. See, you can see the edge of the foramen. I'm burring it and I'm making it bigger. Why? Because the SAP is so big that even if I osteotomize it, there is no way I can deliver it into the canal. I break a piece of bone and I am not able to retrieve it. I'm creating disaster. So I'm now cutting towards the upper pedicle. Now you can see this image. You can see I'm still unable to osteotomize. It's a very thick, huge articular process going out. My scope is looking at it. My burr is there. Not able to do anything about it. So this is the end of it after having cut it. And this is the final image of me having done it out on the opposite foramen. Now I'll show you one more. No, I just jumped this. See, this is the decompression we've carried out at 2 levels. This is where we cut that SAP osteotomy. And, I'll just close this. We will go for.
Welcome to a presentation of unilateral biportal endoscopic transfacetal lumbar interbody fusion at L4-5 and decompression being done at L5-S1, especially targeting the left L5-S1 foramen to free the passage of a trapped nerve root over there. As you can see now in the MRI, patient has a large disc herniation along with severe canal stenosis at L4-5. Here we are introducing the cage, which is 11 by 28 mm long T-leaf cage between the 2 bones at L4 and L5.
You can see the exiting nerve root on the side.
The cage is loaded with bone graft. We are now hammering it in place.
If you notice, I've changed
The final seating of the cage is being carried out. Remnant discal tissue being removed.
You can see the dural edge nicely over here. Exiting.
You can see the well-placed cage within the
exiting from here. I've still not opened up the flavum. Only the little edge of the dura is open. literally extraflaval fusion being carried out.
And the
Flavum is
traversing
intact on
nerve
top.
over it.
Exiting nerve root is here, is not even visualized. The cage is already in. This is the edge.
There are small tissue tags which need to be cleaned. And the nerve root to be probed to check for its freeness, which we are using a dissector to do. This is the removal of the small tissue tags. And now introducing a dissector.
Sir, pranam.
To check the freedom of the spinal cord and the traversing root and the exiting root.
You can see we have put in a cage. You can see the dural edge. The entire process has been done endoscopically. This is where the root is exiting.
Root is comfortable and not trapped anywhere. Now we are proceeding with contralateral foramen opening and superior articular process contralateral osteotomy at L5S1 to free up the trapped nerve root at the left S5 L5S1 foramen. One can visualize the foramen. One can see the edge of the foramen. And now we will be introducing a 2 mm curved round here. Under full visual control across the spinal cord.
Now you see
I'm
in the opposite
and
contralateral
expose
foramen.
completely.
And I'm going now. Here we have done after removal of the
The
flavum.
foramen.
But you see, I'm
I'm working
probing
towards the superior part of the foramen.
small bites, because there is a branch of the radicular artery coming in through the foramen. You don't want to tear it, hurt it, or cause it to bleed.
Going more towards the superior pedicle, inferior edge.
This is across the dura, you can see.
Yes, this is going outside the foramen and taking a bite.
I'm biting
Chunk
of the
of
foramen.
bone.
This is very
At the base of
essential
the
to
superior
deliver the
pedicle.
SAP into the canal. Otherwise, you can't deliver the SAP into the canal.
To make the exiting path for the exiting root a little bigger.
Now you see how
Now I've
introducing the
introduced an
osteotome.
osteotome, a J-shaped curved osteotome,
This is
and
the
placed
SAP.
it on the SAP.
This was the IAP
You can see
which
the
we
SAP,
opened up.
you can see the joint bone,
This is the flavum.
and you can see the IAP. I'm cutting and osteotomizing only the SAP right now. And as we osteotomize the SAP, we pull it in through a maneuver.
Bam.
Yes,
See.
we have fractured and pulled in the tip of the SAP. And now we will be
You can see
extracting
the
the
exiting
fragment.
root below it. See how badly adherent it is. This maneuver has to be done with utmost gentleness to be able to achieve what you wish to achieve. And now,
From across the spinal cord, which is below us.
if I had
Now
not
about
made
an
the
hour.
IAP hole bigger, if I had not cut the IAP, if I had not cut
You
the
can
base
see
of
the
the
pulsating root.
superior
The
pedicle, I
fat
would not
around
have
the
been able
root.
to deliver this inside. And now you can see the opposite root over here. You can see
The cartilage of the
discal
facet
surface
joint
also below
and the
here.
IAP. We have created a large amount of space for the exiting nerve root, which is below, which I'm probing now. And we need to remove some of this phlegm from here and from near where we did the circumferential opening up of the inferior edge of the superior pedicle.
So you can see the discal surface here also.
There's a tag of
phlegm
phlegm
still.
which needs to be cut so that it doesn't compress the root. This is part of what we call as the foraminal ligament, the lateral extension of the phlegm. We will be releasing that to release the pressure on the nerve root. So it's not only the bony part which causes compression, it's also this kind of a tight phleval structure, also called as the guillotine ligament of the foramen, which needs to be freed to completely relieve the nerve root of all compression. There's a lot of phlegm over there, which is superior and above the nerve root,
This was
which
where
we
we
need
did
to
our
remove
osteotomy.
slowly.
That is the IAP. This
So
is
we are
the
using punches,
phleval extension into
which
the
are normally used
foramen.
in arthroscopy. And here you can see a pulsating, beautiful root, completely exposed. There's still a small tag left of the phlegm, which I intend to release.
This over-the-top vision, which is available to you in UB, believe me, is not available in any other form of MI surgery.
As you can see, despite teasing it, it does not easily break.
This decompression I've shown you after removing the phlegm. Now we do decompression without
one
removing
can
the
see the
phlegm.
full length of the pulsatile root below. Across the spinal cord, we are working now. And we are opened up the opposite foramen nicely and completely.
This is the width of your entire root that is exiting below the SAP over there. We're shrinking
This is a
some of the
special
structure.
J-shaped probe which reaches those hard to reach corners for coagulation and ablation of phleval tissue.
So you can see the exiting root now very nicely going
And
out.
helps expose the nerve root.
You can see this
One
nerve
can
root
see a
here.
nice pulsatile nerve root going out through the foramen, with adequate space being created. Here you can see our post-operative result. We have put in pedicular screws only on one side to lock in the cage. My heartfelt thanks to Holy Spirit Hospital. And thank you for your kind attention in watching this video.
I think we'll pause it now.
Thank you once again.
Yes. Now, one last video on para-UB, if you are in the mood before we go for the workshop. Okay. Now, para-UB was designed because even with doing contralateral foraminotomy, sometimes the SAP is so large that it becomes literally impossible. It becomes impossible to even do an internal chop. So we do a para-UB. Now, what is a para-UB? So we'll have that video playing for
Hi
you.
and good evening, friends. Today we are going to discuss Para-UB, how do I do it? I reserve the surgery basically for severe extraforaminal discs and for severe foraminal stenosis. Normally, quite happy. This is.
I'm just jumping a little bit,
So what do I
a
do?
little faster,
Here,
trying to make 19 bits less. Now you see this foramen. You literally don't see a nerve root there, and now you see a huge
There
disc.
is a large disc with flavum. And in the axial cuts, you can see that both the foramens are completely blocked, flavum is thickened. Now, what have I done? I have lined it just anterior to the mammillary process.
I'll just pause over here for a second,
clearing the-
guys.
The mammillary process is the superiormost part of the SAP. And in a collapsed space, the uprighted SAP, it comes literally just at the ischemic point, just below the pedicle. So what we do is we land just below the pedicle in AP. We target the point below the pedicle. And from there, we come a little laterally and we strip the mammillary process because that is where the attachments of the short rotators, the long rotatalis, from 2 levels below the multifidus and from 4 levels below the paraspinalis, all concentrate there on the mammillary and accessory mammillary process. With some extension, even going up onto the ischemic point. So these need to be endoscopically released. You need to identify the facet joint, and then you need to come down along the superior pedicle. I need to come down along the superior pedicular edge, find the foramen, open the foramen, then go for the SAP, because if I do not create space superiorly, then I can't even touch the SAP because the nerve root would get destroyed. So I create space superiorly to make sure that the nerve root shifts a little before I go for the SAP.
That is the bottom line. So now I'll run this video a little faster and you'll be able to understand it a little better. Okay.
Space between the mammillary process, accessory mammillary process,
So this
and the
is
pedicle.
creating all that space. Here the superior
What
artery
is
will
attached
come,
over here?
facetal artery will come.
You have an attachment of multifidus strand coming from the lower level.
All
And
that
you
needs
have
to
the
be
rotalis
stripped. I'll just
and
run a
the
little
surface
faster.
of the facet. I want to take up a position wherein I am within the capsule of the facet.
Now I'm inside. I'm going to go down
slowly, gently
subcapsularly. I'm going to
walking
enter the
down that
facet.
path
I'm joint capsule and I'm
until I
going to
come to
slide
the
down it.
facet, joint, and to the foramen below that.
The philosophy
Here
for
you can
that
see
is
I'm
to stay
burning
away
the
from the
sand
direct
in the
perforating
surface.
branch that is coming from the aorta.
And a little bit of bleeding control. Sorry. And you can see
Now you
how
see
the
me exposing
mammillary
the
and
facetal
accessory mammillary
surface.
processes are in your view. You can see how the isthmus part of the lamina is in your view. And now we will start our journey from here, going a little towards the
This
transverse
was the superior
process over here.
surface. Now we are coming towards the transverse process.
And now away the synovial tissue inside
Now,
the facet. See,
on
can
the
you see this?
SAP,
Yeah. This is
IAP,
the
see this
tissue.
red tissue here?
The vessel
That
here.
is the synovium of the facet joint.
I'm gradually going there and I'm gradually burning away on bone and trying to go downwards. I will come laterally, I will coagulate that vessel into the direct descending branch. And here I am burning away the synovium, along with that the vessel, and I'm achieving good control. And as I burn away more, you start seeing the IAP, SAP joint.
Now can you see the facet
That's the
joint coming in
facet
view?
joint.
This was your
And you
IAP.
can see how I'm
Above.
struggling and working my way down.
This was the
Within-
IAP. This is the
within
joint coming in view. Now the SAP is coming in view.
This is the key
This
to
is the
going down.
facetal capsule. Can you see a perforator here?
All this tissue that you can
Now
see,
this
frontal
perforator
tissue that you see.
Can be easily
fronts of
controlled.
the
The synovium that is red can be easily burnt away.
So I'm
And
trying
when
to,
I come
as far as
down deep,
possible, go as
until I
deep
come to
as
the
possible,
psoas
keeping
fascia, I
myself
continue this way.
within the capsule.
Once I reach the
Attaching
psoas
the
fascia,
capsule
then
a
I
little
cut
bit
the
here and
capsule
there,
laterally to become
making
more
things
horizontal.
looser, but going further and further downwards. I take multiple shoots at this time. I locate myself nice. and confirm.
Now
You are less worried about directly hitting a major.
you can see this is the superior pedicular wall,
coming from the aorta,
and now
which
this
would
I'm
cause
reaching the
severe
floor.
bleeding. And then the struggle to
Now
control
this
the
floor is covered by the
So being
fascia over the psoas.
intracapsular and
As
then
long as you don't
gently
open
when
this
you go into
fascia,
space,
you will not
I feel
create
is the key, the very
retroperitoneal
key
collection of
element
fluid. Fluid will
to
pour
doing a
out.
good para-IUP. As you can see, our field of vision is quite nice. Okay, the joint over here.
Now I'm burring away the
Capsule.
superior pedicle to create space
Okay. Now, as you
for
can
a very
see,
tight
I'm burring away at the pedicular wall.
foramen.
I'm going to create space superiorly first. I got great advantage of being atrial. But as you can see, I'm not able
Now
to
this is the
completely
SAP
delineate.
which I'm burring
So
away.
big.
And where is the root? The
It's so
root is
big.
here.
And it's
In
crushing
this
the
little
root so
strip.
badly.
This is the SAP. This is the IAP. This is the pedicular wall. Now after
So
burring, you're
now I
seeing
have to
so
really
much.
think,
Otherwise, you would have seen
what should I do?
nothing.
So I'm trying to remove some of those tissues, some of the synovial tissue which is lying over the root. This is part of the ligamentum flavum which covers the root.
This is the flaval extension which I'm teasing. This is the root below it. This is the identified SAP. And this is after cutting so much of IAP that I'm able to visualize so much.
So
Otherwise, the visualization
now
was
I feel
literally
I am
zero.
command of the situation. Is being obstructed by this little bone over here from the
Now you
SAP.
can see how I'm thinning out a huge
So I want to
SAP,
make
burring
some
it,
more
making it
space.
smaller, smaller.
So that I get a direction and angle for my kerosene to go and take a bite. Okay. And believe me, this is such a tight foramen. We are still miles away. A lot of thick flavum there.
Now you see how I'm cutting away
So
still
I'm
further
not really
up.
scared that
And you're seeing
I
the
will
flavum below the
capsule
burr.
cord or lumbar spinal cord or whatever. I'm quite
This was a
confident
redo surgery
I
in
can
any
still
case.
manage with some little gentle burr in front of our eyes. It's a huge piece of bone. It's badly crushing on the nerve. So here you can see how nicely the synovium is being seen
This
over
is
here.
the SAP.
So you see the
Still,
synovium and the capsule which have been opened up by me. Yes. Now I'm going to introduce a J-shaped osteotomy. No, before that I'm probing away. I again want to see where the root is, how badly it is still stuck. And you can see from my probe tip how deep and how big the SAP is. Now I'm placing an hockey stick chisel.
now this is
And
osteotomy of the
I'm
SAP
cutting the
from
tip of the
outside. What we saw in the previous video was from inside.
Poke, poke,
And
and poke.
small chips.
And yes, we
And
fractured
creating
the
some
tip of the
space.
SAP. We've mobilized
Flipping
it
the bone.
with the hockey stick chisel in place. A little bit of bleeding coming from the canal. Because the canal is more
Now the
open.
epidural space is open. The dural canal is open from
I'm
the
trying
inside.
to retrieve the piece, but the piece is large. So what do? I try to hook it. I gently play around with it. And I try to hook it within the foramen. You can see how big this tip of
Now
SAP
if I had
is.
not cut the proximal
That
foramen,
despite me trying to mobilize
how
it,
would I have been able to
I'm
manage
not
this?
able to mobilize it.
It would have been
Quite some
impossible to
effort.
get
So
this out.
finally, I think I decide that I will try and free it from some more tissues, make it a little more loose and
There is a little flavum attached to it, so it's going to be
Okay.
tough.
and then use a
You
kerosene
see
to
my
grab
struggle.
that bone.
Now a
Hold it
kerosene has
tight.
gone below its base. I'm able
And
to
then
hold it, pull it
Pull
into
it
the
out
foramen.
into the outer
But you
foramen.
see how big it is. It's still refusing to come out.
And let's see how much of effort it is taking. How big this piece of bone is.
I'm literally
Oh,
struggling to pull it out,
It has slipped out from its lock
but it's come out now.
from the inner foramen. So again, I'm introducing a punch. And holding
This is where a
piece
curved
of
kerosene
bone
helps
chunk
you.
and removing it.
And now finally the
Once
piece
I
is out.
remove it, you can see the epidural space that is bleeding. And now I'm removing some more of the superior pedicle so that
You can see how big and thick the pedicular wall is also.
now what I want you to see
Endoscopically,
here,
obviously
is most
magnification is more.
you can see a free root.
And you
Also
can see
tile.
the root pulsating over
You
here.
can see the SAP tip which has been cut.
This is the flaval extension, which is still
What is
on top
this,
of the
guys?
root.
This is the discal surface.
And this is the discal
It's
surface
wood
here,
or not?
white.
It's a hard disc. IUB. I do not wish to strip the root more. There's a lot of fibrosis around the root, and if I remove these tissues, I will again have more fibrosis. So
It was a
really,
redo
I don't know
surgery,
whether it makes
previously
any
open
sense.
surgery,
it's better to
collapse.
preserve some of these tissue tags around the root.
This is one of the
And,
reasons why when you see
it's
this
even coming
fibrosis,
out
you go in a
completely out
redo
of the
surgery and you rely on the
So,
principle of
foraminal-
indirect decompression.
inner part of foramen.
If it is such a badly
Middle part of
trapped
foramen.
adherent root, the patient is
And
going to
outer
wake up
part of
screaming
foramen.
either with a foot drop or
All
with severe
completely
root
decompressed.
dysesthesia.
You can
Why?
see
Because you have not
beautifully
taken the effort to
the
free the
discal
root.
surface below.
You think your indirect
Okay.
decompression is going to solve all your
If I
problems.
remove
It
some
doesn't.
more of this bone, obviously I will be able to see.
But it's like this case. These
More
are
of
the
the
pathologies that we had
spinal
never
cord.
seen before.
Now I've gone
Now I've gone on
of the
top to carry out my
facet,
regular
and
fusion
I'm
surgery.
starting to clear the interlaminar area.
This is
And I'll
the
be proceeding with
interlaminar
central
sweep.
decompression, but that
Okay.
is, gentlemen, another story for another day.
Now, this is
Now,
where you land.
What you see in this X-ray is the landing at the ischemic point. You can see my probe, how it is at the junction of the transverse process, and the
Identifying the
this
extent of
X-ray
the
shows
facet
the
joint.
lower extent of the stripping that I've done on the facet joint. Okay, creating space all along the facetal corridor. And I hope you guys really enjoyed this video. This is how I do it. Good night, Shabak Khair. Thank you very much, my dear friends, for being so patient with me.
So I hope you enjoyed a video on para UB. There's much more, but I think we'll stop and we'll start with our workshop. So at least the basics, I think I've explained to you all nicely. I hope you all have enjoyed these videos. Any questions? Anything making any of you uncomfortable? Because I understand you're seeing a different world. Alag si dunya hai, alag si cheezein hai. As open spine surgeons, we take many things as assumed, but in endoscopy, the paradigm changes. The whole thing is totally different. But anyway, it's fun. It achieves its job. It's wonderful because now I've started doing it most of the time in awake anesthesia with patient only under sensory epidural. Just 3 days back, I put up a video on a K-lift. I've done a K-lift. I've done a transcam infusion with the patient completely awake at L5S1 with a very high angle of approach, which would have been otherwise considered impossible. I put in a 10 millimeter pitch with the afternoon in an awake patient. Same thing with UB. I started doing UBs also and UB fusion, which will be my talk. You'll see my patient nice and awake, like an hour is awake, in elderly gentleman, hypertensive, diabetic, ejection fraction was barely 38%. He was not fit for general anesthesia under any circumstances. And he needed spine surgery. So rather than give him a journey through an ICU, I gave him a journey which was much comfortable. So we have been doing many things, adapting in many ways, changing many things. Endoscopy initially was transforaminal, restricted to a little this, but today it literally covers the entire spectrum of degenerative spine. Percutaneous screws, fixation, rod, the same 2 small portals. So you don't need an additional cut unless you use a Metronics device, because then that does give a third cut. Okay, but apart from that, the entire spectrum on degenerative spine. I showed you a cervical UB video, cervical laminoforaminotomy, cervical disc excision. So motion preservation surgeries and minimal is less is actually true. I do not decry what my predecessors have been doing or are still doing. Tubes have a role to play. But today we are much beyond the tube, because we are seeing at the spot rather than through a microscope. And we are much more flexibility with our instrumentations. It's a free hand technique. It's like initially when you learn to eat noodles with a chopstick, it's a little difficult. But then eventually we try also with a chopstick.
So that's the way it is.
I think we'll get ready for the workshop. Okay, guys? I hope you enjoyed the talks. Sir, thank you very much.
Pain. The second thing you have to avoid is so-called siloed spine care. Most countries in the world, you have tertiary hospital care and universities where all the surgeons and medical specialists are and the high-powered equipment. You have district hospitals and clinics where you have family physician and nurse practitioners. You have private practices where most of the chiropractors and physical therapists and occupational therapists work. And then you have the villages, which is the majority of the population, which is basically the treatments maintained by traditional healers, police, first responders, and community health workers. These are multiple different professions who have different training, different terminology and language. Often non-evidence-based interventions have been prominent in their curricula. There's been no communication between them and no real coordination. The third point is that you have to avoid unlimited and indiscriminate increase in spending on spine care. This study by Dieleman in JAMA estimated that in 2005, $87 billion has been spent on the management of back and neck pain. And that had increased by 57%, 57 billion since 1996. But that didn't stop there. A recent study showed that in 2016, low back and neck pain had the highest amount of healthcare spending among 154 different conditions, with an estimated spending of $134 billion. Now, this does not count the disability, the impact of society. We did a study which showed that disability probably adds another 4 times as much disability cost to society. So we're talking $500 billion in the United States is what low back and neck pain is costing society. And if we look at the data, it's almost all the high quality, the high cost care, imaging and expensive testing, opioid and other prescription medications, epidural steroids and other forms of injection, fusion and surgery, all have shown this exponential increase in the number, in the cost and the number of procedures which occurred during the period. Deo and Martin published a paper which showed that during a period of time when total expenditures increased by 60%, the amount of functional disability and limitations due to back and neck pain increased by from 20 to 25%. We're talking about if you throw money at it indiscriminately, the increased expenditure actually increases the amount of disability. So what we've managed to do in most of the Western world and the high-income countries is focus on the tertiary care, the highest quality care, and ignore the primary spine care and the low-income and the prevention, which is where the majority of the population should be treated. We've been giving the wrong care to the wrong person at the wrong place at the wrong time. So what does World Spine Care bring and the Global Spine Care Initiative have to do with to offer Nepal in this venture? World Spine Care is a nonprofit charity registered in the United States, Canada, and the United Kingdom with the goal of helping people with spinal disorders in underserved communities throughout the world. You'll hear more about it from other speakers. But basically, we have open clinics in Botswana, India, Dominican Republic, and Ghana. We've had educational courses and conferences in Botswana, India, Nepal, and other places. And we've done a series of research studies, including the Global Spine Care Initiative and Guidelines, and you'll hear about the implementation and outcome study. The Global Spine Care Initiative was an initiative that was put together with a multidisciplinary task force of 68 spine care clinicians and researchers from 22 countries. It was for development and evaluation of innovative integrative model of care to improve the management of spinal disorders with the goal of reducing the associated global disability and burden of disease. 15 papers were published in the European Spine Journal in 2018, which outlines the details of this study. Basically, it comes down to the following. There are three major components of society of spine care. The first is community-based programs. The second is primary spine care. And the third is secondary and tertiary spine care. This is where the main hospitals and so on are. This is where first triage and non-surgical interventions are given, as well as the diagnostic decisions. And the community-based is where education and monitoring and sorting people out for those who require care and those who do not. We're talking about working with a primary care provider team with a close integration with secondary and tertiary spine care and self-care and community practice as a well-oiled machine interacting with each other in a consistent fashion. We're talking about the majority of people in the community having access to self-care and community programs. Those who require triage and some form of treatment have access immediately to a primary care contact spine care clinician. Some of them require secondary care at district hospitals with some basic testing, and a few are sent to those tertiary spine care centers, which require the high-powered surgery and specialist care. If this is done correctly, these people will only see those patients who require their level of care. This is the right care, the right person, right place at the right time. It's a patient-oriented program, social work and community program, service workers or first responders, unlicensed healers or self-care, licensed healthcare practitioners in primary contact, community hospitals and community emergency rooms, and tertiary hospitals and multidisciplinary interventions. It's coordinated care between these groups with triage to ensure that patients end up in the correct category, as noted below, and you'll hear more about, coordinated evidence-based spine interventions, and integrated primary contact people with a great deal of education and collaboration. In conclusion, you're going to hear a lot in this symposium about this model of care and the problems associated with spinal disorders and how they could be alleviated. You're going to hear about what's happening in the rest of the world to try and deal with this problem. And I hope you find it useful. The conclusion is it is possible to improve the quality of life and reduce disability resulting from spinal disorders with an evidence-based, patient-honoring model of spine care.
Thank you, Professor
I want to thank
Scott.
you all, and I look forward to and hope you will enjoy listening to the other speakers in this symposium. I'll be available to answer questions and direct questions at the end of the symposium.
Professor,
Good afternoon.
thank you, Professor. We will take the questions at the end. Now we'd like to invite our next speaker, who is going to be connected with us virtually, Deborah Kopensky. She's going to talk on global burden of disability and its impact in Nepal. Is she connected? Oh, she's not online. Shall you go ahead with the next speaker? Yeah. So how is treatment of spine pain delivered in Nepal currently? Dr. Bimal Pandey, he's going to talk on that topic.
Good afternoon, everyone. I'm very pleased to be here. I feel honored by NESON and everyone here. And thanks a lot for inviting me to speak a few words about the spine care and spine pain management in our country, how it's been carried out. Slides. Yeah. To start, how is the treatment of spine pain delivered in Nepal currently? Spine pain, this is one of the most common cause of disability in developing world. So in our country, if we go to the rural area, even more spinal problems are there, which has to be tackled carefully and which hasn't been dealt till now. But in urban areas, some of the spine pain has been managed pretty well, but we have to do a lot, especially in rural areas. And different modalities of treatments are there. Physical treatments, rest, exercise, physical modalities, usually it's been done by physiotherapists. And gradually this modality of treatment has been promising and getting advanced in our country as well, but still it's in the urban areas, not outside the Kathmandu Valley or in rural areas. Another modality of treatment is medical treatment with the help of medicines and some neurosurgical interventions or non-neurosurgical interventions. These are generally done by the pain physicians. There are some group of people, actually they're from anesthesiologists, and for the last few years they have been coming up with different type of pain identification. They are trying to find out the pain generators, and non-surgically they are trying to get relieved of this pain and helping out of the people. And another is surgical treatment done by spine surgeons. And treatment is carried out by different professions. All these three different type of treatments have been it has been carried out in our country by different type of peoples with different modality, different educational group or different type of traditional group as well. And our government hospitals are there all over the country. Regional hospital, there are 6 regional hospitals in our country from east to west. And these regional hospitals are well equipped with the facilities to take care of a spine, starting from physical therapy, some medicine, a little bit of intervention by anesthesiologists, and other surgeries are also in some of the hospitals. And other general hospitals, 11 general hospitals are there all over the country, and they are also a little bit advanced in terms of taking care of the spine pain patients. And central hospital, 11, and these central hospitals are located mostly in bigger cities, mostly in Kathmandu and bigger cities, and mostly the people from outside the valley and rural area are facing difficulties to get the treatment, simple treatment for spinal care, spine pain in the centers like those. And there are government teaching hospitals, 5, and there are 15 private medical colleges giving services to the spine patients. district hospitals, 56. In district hospitals, though there is very less facilities of other specialties rather than physician and clinicians. Physiotherapy and other modalities of treatment are not in that advanced stage in those hospitals. And the investigating tools are also not easily available in those hospitals. The plain X-ray is the most that people can get in those hospitals. There's no questions about CT scan, MRI, nerve conduction test, and others. And 15 bedded hospitals are there. There are 13, and these are very small, run by few doctors, few physicians, even not specialized doctors, and they are taking care of spine patients over there. But besides spine care, they have to take all the patients, from patients of general surgery, chest infection, or urinary tract infection, whatever. They are taking care of all the sorts of patients, and they are not well versed with the spinal problems. And if you go to the website of Ministry of Health and pick this, and what's about the private institutions? Those were the government institutions. And what are the facilities that have been provided by the private hospital? If you go to that column, you'll see list of private institutions. And starting from the one, if you scroll it, you'll be tired of scrolling this. Altogether, there are 962 different institutions, private institutions, only in Kathmandu Valley. Out of those, more than 50% are clinics, polyclinics. Few, and 1/3 of those are dental clinics, and few laboratories. But more than 50% are the clinics, private clinics, only in Kathmandu Valley. These sort of different type of, and can you imagine, do we have that manpower in Kathmandu Valley? Obviously, no. We can imagine how these have been giving the services to the spine care patients. And beside those, we have other facilities, other team of the people who are taking care of a spine problem in Nepal. Unani hospitals, Ayurvedic hospitals, homeopathic centers, they have their own protocols of treating. They have own diagnostic tools, which doesn't correlate with our modern or with our allopathic medicines. But some of the Ayurvedic hospitals are now, they are trying to read X-rays, they are trying to do some ultrasound to diagnose some of the diseases, and even they are doing a little bit of hematological blood investigations nowadays. Otherwise, homeopathy center and Unani hospitals are not, they have their own ideas of or definition of the spine pain, but they are giving services to our people. And the difference between Unani and Ayurveda, a little bit of difference there. And another one is nature care hospital. Nature care therapies are there. In our country, we don't have any institution that gives proper training of, or the proper educational training to those people. And nobody knows where they come from, but there are few centers and they are running and they are taking care of good amount of people in our country by themselves, and Ayurvedic clinics are there. And going through, there are lots of advertisement, or they have very good websites in the internet. You can go there. And one of the Ayurvedic hospital there, and they are doing a little bit of some kind of surgeries as well. And if you carefully see how they are equipped in the operation theater, look at how they are wearing their masks. And some people are wearing masks, but without coverage, head cover. Some of them are using head covers, but with no mask. This is the scenario. This is also one of the institutions where spine care is being taken place in our country. There's a manual therapy. And till date, I don't know, there are not much of the chiropractor or well-educated chiropractor now in Nepal. But still, there are few centers who claim that they have chiropractic facility over there, and they are doing some manual therapies, but they are not having a good degree of their professions, but still they are treating our patients. That means our population is getting treatment over there. And investigation, what are the investigations that we are doing to get to further treatment of spine pain patients in our country? X-rays and other hematological investigations, ultrasound, CT scan, MRI, nerve conduction test. And if there's any pathology in spine, aspiration, cytology, microbiological tests are there, and even a biopsy. But how many of the care provider are well versed with these type of investigations? Usually physicians and surgeons, and now the physiotherapists, they can read the x-rays, and they have they look for the MRI findings, and they correlate treat their clinical disease with the radiological finding. Even some hematological tests are being done, but most of the spine care providers that I listed above are not well trained how to interpret these investigations. But without correct investigation or evidence, people are being treated by themselves. And physicians and surgeons, Association of Spine Surgeons of Nepal and NESON, this is spine chapter of NESON, and anesthesiologists who have their own, this Nepal Association for the Study of Pain, they come out with evidence-based practice, and they're doing the right judgment. But the number of the people giving care is very less. Spine surgeons and physicians are there in our country, even physiotherapists. And another group of people are there. There is a pain surgeons, pain physician, physiotherapy are there, natural therapy, Ayurvedic medicine, others. But what I do is only the treatment of spine pain. Everyone thinks that what is doing is the right, and that is the way how to treat the spine care. This is wrong. There's no correlation in between or connection in between those specialties. The person who has gone to one specialty, one center, will be held till the end. That is the thing that we have to correct, and we have to correlate. And a lot of times, spine surgeons are doing surgeries which could be well tackled by plain physician or by physiotherapy. Overuse or over indication of the spine surgeries is being done. In reverse way, some of the physiotherapists, in that some of the patients with some early developed neurological signs and symptoms are not picked up by the specialties, and they are held with continuous physiotherapy. That means no one is perfect in this group. No one is the Superman in this group. Everyone need to be in touch. And if we are able to make a chain in between, then we'll be able to provide a special spine care to our population. And another one point I want to mention is the pharmacy. This pharmacy, you can see, this is a shop. This is the first caregiver in spine pain in our country. A patient having back pain, first of all, he go to the nearby medical shop, just a 2-stepper, right? Go to the shop, and he gets free consultation over there. And on top of that, he gets medicine. And he uses that medicine on and off, and usually they provide painkillers, and patient gets relieved of the pain a couple of times. Again and again, he repeatedly go to the shop and buy. And the shopkeeper, that is the person who refers that patient to the hospital. Now you should go to hospital or physiotherapy. This is that's why the role of the pharmacy is the first step still in our country. So I'd like to conclude that this is the scenario, current spine treatment that is being done in our country. Taking care of spine pain shouldn't be generalized. Teamwork always gives a better outcome. referrals and interspecialty consultation is advisable. We should develop common language between all the stakeholders taking care of spine pain, and should understand one's limitation. We should understand our limitations. Thank you very much.
Thank you very much, Dr. Bimal Pandey. He is the president of Association of Spine Surgeons of Nepal, and he worked a lot for this presentation, it seems. The next presenter is Dr. Jeff Outerbridge. He is the clinical director of World Spine Care, and he will be talking about what is the Global Spine Care Initiative and how it can help. Dr. Jeff Outerbridge.
Thanks for the introduction. The timing of this is kind of good because the last two presentations have talked about what are the problems with spine care, and not just in Nepal, this is around the world. And what I hope to offer today is a little bit of a glimpse of how we might solve some of these problems. When we first started, Dr. Haldeman talked about the model of care, the Global Spine Care Initiative, how things have to integrate. And you can take an ideal model like that, but when you try to apply it to a particular place, you realize that modifications have to happen. And so what I'm going to go through are some modifications for those people who've seen the presentation, the workshop we did on the Global Spine Care Initiative. You're already going to start to see some changes. Dr. Boussier and I just spent a week out in Gutshore with Dr. Kadka in the frontline healthcare clinics with patients at the Carnally Academy of Health Sciences, gathering a lot of information and coming up with some ways that we can actually make this a little more relevant to Nepal. So I'm going to try to bring you through that. And along the way, I've also added some of the photos that I took while we were on back there. So hope you enjoy those. Okay. So to address this burden of spinal disorders, the Global Spine Care Initiative was developed as a model for prevention and care for people who have spinal disorders. And this was a model that could reasonably be instituted in communities with different levels of resources, all the way from remote, all the way through to tertiary care. So Scott already reviewed this, the Global Spine Care Initiative, multidisciplinary task force, innovative integrated model, and it was published with 15 papers in the European Spine Journal, so I won't go through that again. Kind of stole my thunder. So when we talk about level of spine care within a country, the very first level of spine care is at the community level. That's where most people are going to be entering the system. And in that location, there's a lot that can be done in prevention and community education. But when somebody actually starts to have pain, then they're going to need to see somebody who has some specialization in spine. And we were calling this the primary spine provider, primary spine practitioner. And the concept of primary became a real stumbling word along the way because everybody was saying, well, we should be primary, we should be primary. Well, the primary contact could be many people throughout the system in Nepal. So instead of talking about primary contact, which everybody can be, we're going to talk about the non-surgical spine care. And then there's a secondary care. And as you go up the levels of spine care, the cost of the interventions become larger and larger. So at that community spine level, this is the health and prevention, physical activity, education about smoking or drugs or osteoporosis and other risk factors. And that can all happen at the community spine care level. When a patient actually presents with pain, then they need to actually see somebody or any spinal symptoms. Now, they're mainly going to be managed by the non-surgical spine care specialists. They're the ones that have the expertise in education, exercise, manual therapy. When it comes to patients presenting with neurological disorders or deformity, some of those neurological disorders can be managed in non-surgical spine care. Some need to go to secondary or tertiary care, and it's the same with deformity. a stable scoliosis with mechanical back pain can be managed by a non-surgical spine care provider, whereas a progressing scoliosis needs to be seen in tertiary care, potentially for bracing or surgery. So they can go either way. And usually red flags are going to be seen at that tertiary care level. And in terms of what proportion of the population really need to be seen within these different levels, the majority of people who are suffering from some are actually not going to have pain, majority, and no risk factors, but it's important to educate in advance. Or they may have some risk factors for developing spine pain, and the prevention and education programs become very important. But then when patients actually start to have symptoms, 90% of those are going to need non-surgical spine care interventions or a non-surgical spine care provider. And then as we go up, some might need secondary care and very few will need tertiary care. Usually around 1% of those presenting with spinal pain actually need surgical interventions. So what the Global Spine Care Initiative is trying to do is trying to get the right care for the right person at the right time, so that anybody presenting with spinal pain, no matter where they enter the system, at the tertiary care level, secondary, the non-surgical level, or the community spine care level, no matter where they enter, people, clinicians at those levels can make the appropriate decision to put them into the appropriate level of care. Okay, and that's kind of what we're trying to do with the Global Spine Care Initiative initially. Get them to the right care and get them to that care as quickly as possible, because the quicker the interventions, the better the outcomes. So if we look at community spine care workers, this is out in the places like Butchor, where we just were, where you have paramedics, nurses, community health workers, and this is where patients are going to present first with spinal pain. And they're going to be primary contacts. We want, it's ideal if they have a basic knowledge in spine triage. They can identify red flags and make that decision on, again, when a patient should leave the community and go and have care, or can the patient stay in the community and be managed there. So they'd be trained in spine pain prevention and community education as well. Trained in conservative interventions, including education, maybe some basic exercise prescription, but as time goes by, they can be trained more and more and more. And then safe transport and handling of patients. We've heard a lot of patients who have had spinal fractures and are thrown in a truck and driven for long ways without any spinal stabilization. So that sort of education as well. So that's a community spine care worker. Now, what we just worked out is that red flag screen. And the color coding in here actually matches the different classification system, which you're going to see in a little bit. But these are questions that we try to make very clear and very direct, so that anybody, whether it's a physiotherapist, first person seeing them, or a surgeon, or a medical doctor with no background in spine pain, or a community health worker, a paramedic, they can run through these questions and decide, does this patient really need to go and see a specialist or not? Okay. And all of these, all the way down to number 8, are red flags referral. And then number 9 is one that can be referred for that non-surgical spine care at this point. We'll elaborate on this a little bit. So the non-surgical spine care clinicians, they're providers. They have specific knowledge and skills in evidence-based spine care, manual therapy, and rehabilitation. So this in Nepal would best be represented by physiotherapists. In other countries where there are chiropractors who are properly trained chiropractors at proper chiropractic institutions, they also have that level of training. So that's who we're really talking about. This can be delivered in any healthcare setting. However, physiotherapists are usually in hospitals, either secondary care or tertiary care hospitals. They're not usually on the front line way out in a remote village. They're going to be integrated into the healthcare delivery within the clinics, hospitals, or ambulatory care facilities. They may act as primary contact, or they may act as a referral. So again, the primary contact may be a surgeon. Surgeon decides through these questions that they're not a surgical case, or their own guidelines, they decide it's not a surgical case. They're referred to the physiotherapist for that non-conservative care. And they actively collaborate. This is the communication that both the last presentations talked about. It's really important for there to be collaboration, and this isn't a siloed care. So the physiotherapists, the non-surgical clinicians are actively collaborating with other healthcare providers. And that may also include OTs, rheumatologists. It's not just surgical, non-surgical. This non-surgical group is a little bit bigger, but the core element of that would be the physiotherapists. And they may also be referring back to community care or surgical care when indicated. So the surgical care, spine care clinicians are going to be the secondary or tertiary care settings, may act as primary contact or referral from other healthcare providers. We've heard from surgeons in certain areas saying, we want to be primary contact. We're okay with that. We've heard from other surgeons saying, I'm so busy, I want somebody else to make a lot of these decisions, so that the only cases that come into me are the ones that probably need surgery. So the surgeons, may or may not need that non-surgical triage person to do the triage for them. These are the surgeons who have specialty training in surgical interventions for spinal disorders. So the orthosurgeons and the neurosurgeons. And again, we're hoping that they actively collaborate with the other health professionals, and they can refer to the non-surgical or community care when appropriate. So the steps of the Global Spine Care Initiative are: first, somebody becomes aware of their pain. Then they go through that initial triage. And once they have gone through the initial triage and questions, they can be classified into the major classifications. Are there minimal or no symptoms? Do they have moderate pain or mild pain? Do they have moderate or severe pain? Neurological symptoms, spinal fracture, deformity, or any serious systemic pathology. And then now comes the provider assessment. So this is where the non-surgical spine care providers, surgeons, medical doctors, all of them can use this provider assessment, because these are healthcare providers that know how to do a proper history, physical examination, diagnostic testing, and ask additional screening questions to then subclassify the patients. And the subclassifications are: if they're class 0 and they have no pain, do they have risk factors for pain? Do we want to educate them, or do they have no risk factors? Class 1 pain, is it acute or chronic? We're going to treat them different. All the physiotherapists here know that we treat acute and chronic pain a little bit differently. Same with moderate or severe pain. If it's acute or chronic, we have different things that we do with them. So, and in neurological, we've got minor, non-progressive neurological symptoms, acute, major, progressive, and then stable neurological. Under fracture and deformity, there's stable asymptomatic or acute and progressive. Under class 5 pathology, is it acute and severe, slow progressive, or a non-spinal referral from non-spinal structures? So each of these then has, after that, then there's a series of flashcards that you use to decide what's an appropriate intervention for that patient, and then monitor outcomes. So with the provider assessment, again, this is going to be performed by the surgical or non-surgical spine care specialists. Spine assessment, history, assessment tools to measure pain severity, disability impairment, psychosocial risk factors, any red flags, spinal, neurological, and general physical examination, and appropriate diagnostic imaging or laboratory testing when appropriate. And then the assessment, the assessments provide the information for that additional triage and to decide what class and subclass that the patient belongs in. So then what happens now is, let's say a patient presents to a physiotherapist, they're going to ask the same questions that they would in the front line. They want to rule out the red flags. But initially now they need to know the subclassifications that they would deal with. And is this a pain, a type of pain that we can manage? And if so, how do we manage it? So even a surgeon can look through this, or a medical doctor, and go, do I refer, or do I refer to surgery or emergency care, or do I send to the non-surgical specialists? So the physios are getting more appropriate referrals directly to them that should go to them. They're knowing when to move up to surgeons for more surgical interventions. The surgeons know when to move down to the non-surgical care. And so everybody has an understanding of where a patient belongs when, and that helps coordinate the care. And then everybody starts talking that common language that was mentioned in the last presentation. So this is, again, decisions. Is it signs or symptoms of serious pathology? Then it's class 5, and there's a decision that goes along with that. So once you've decided the class and subclass, then there's a card, a flashcard for each of the different subclassifications that lists the evidence-based interventions, what we should be doing for that patient who presents with those symptoms. And this is what the neurological flashcard looks like. So it has a subclassification, what are the assessments that should be done, and what are the interventions that are evidence-based. And we have cards for each one of those subclassifications. So the overall benefits of this global spine care initiative model is that it addresses the whole person, family, community, and biopsychosocial model. It improves the outcome by getting the appropriate timely care. The patient benefits from that clinician communication. It creates a language and confidence between clinicians around spine care. The surgeon saying, well, we think that the physiotherapists sometimes hold on to patients too long. Well, if that Global Spine Care Initiative decision tree is used every time a patient comes in, then if there are emergent symptoms, then they'll be more easily recognized, and there's a better chance that the non-surgical specialist will be referring to surgery at an appropriate time. It also contains costs. There's going to be less imaging, medication, surgery, and minimal treatments at the inappropriate level of service. This is person-centered care. The patient is at the center of the care rather than the actual service. And at the community level, the benefits are appropriate referral. Patient goes when they need to go to the hospital, and they stay in the community when they don't need to go. It minimizes that unnecessary travel. There's education and prevention programs aimed at reducing the burden and preventing spinal disorders. For the non-surgical spine care specialist, it provides evidence-based roadmap for appropriate care for any presenting spine complaint. Okay, and so the actual full package is really of best benefit to the non-surgical spine care specialists. And it gives a provider confidence in their decision-making and confidence in the other providers they need to communicate with in that decision-making. For the surgical specialists, it gives awareness and confidence in the non-surgical services. And the referrals they get are actually more appropriate. They're not seeing patients that they don't really need to, and may relieve the burden on tertiary care, surgeons not seeing those non-surgical patients. So on Sunday, there's a little thing in your schedule that says we'll talk about the Train the Trainer program. That's actually a gathering that we're going to have on Sunday between noon and 4, and we invite anybody to come and participate in a discussion on the Global Spine Care Initiative and its implementation in Nepal. We need your feedback. So far, we've got a lot of feedback. It's been amazing. And we've really modified things, and we think we're getting closer and closer to a model that really will work in Nepal. And anybody who can come and give feedback and ideas to us on Sunday would be great. Thank you.
Thank you, Dr. Jeff. Now we'd like to invite Niva Bajracharya. She's going to talk on primary spine care providers.
Namaste. Thank you very much for inviting me to speak on this topic. I'm Niva Bajracharya, lecturer at KMC Hospital, and I am also working as one of the core team members of World Spine Care core team group. And we are working together to develop a national spine chapter. So you all must be surprised that my topic of today has been a little shuffled and changed and modified. And this is, as Geoff just in a earlier presentation has explained, like how the primary care providers in our context, how the primary care providers are not a certain facility, like people can land up anywhere. So GSCI model, it is a very flexible model. So as they are taking to different countries, they have been modifying as per the convenience of the context of the place where they are going to apply the model. So this is how my topic has been changed, and the primary and classification of the care providers from primary care providers have been changed to healthcare workers, non-surgical spine care providers, and surgical spine care providers. So today I'm going to speak on the role of non-surgical spine care specialist. So why non-surgical spine care specialists are so important? Because as you all, we have come to know that among the 90% of the spine care, spine problem patients that we see in the hospitals or clinics or anywhere, the majority of the patients that come along are the non-surgical spine cases that don't need to undergo surgery. And we being the physiotherapist, we have the major role in being the non-surgical care providers, because as we know, we have the authority, or we have the knowledge of triaging it, and then whether to refer it to these different department, or whether to keep it for ourselves for further treatment. And lots of discussions has been coming in, like different faculty not referring patients to other faculties and keeping them to themselves. Like Dr. Bimal also very rightly said, the patient who enters to certain faculty stays there for long. So this module is to enhance the interdisciplinary network and team and discussions and talk about this. So the non-surgical spine providers, they are generally in the clinical settings and all. As Jeff has already said in the previous, why are the non-surgical spine care providers are very important in this field? Because they have why they have such a potential role as a non-surgical spine provider? Because they know to triage between the red flags, they know to see between the yellow flags if they have any biopsychosocial issues, and even if they need to treat or manage it, they give the exercises, they know the manual therapy that we give, and they have different protocols on how to treat different kind of spinal care problems. And even if while treatment, even if the patient has to go under surgery, we come across the progressive symptoms, then we can always refer them to the surgical care providers. And before that, we can always do the pre-surgical conditioning before referring them to surgery. And as we all know, after surgery, they are always mostly coming back for the rehabilitation process, that is post-surgical rehabilitation. And also another important point why this role is very important is non-surgical care providers gets the maximum time to spend with the patient. We all know we don't spend less than at least 25 minutes to 40 minutes, or sometimes even longer than that, while we treat our patients. In the process, we talk to them, we get to know about if they are going through any biopsychosocial issues, then we can refer them to the psychologist. If not, if we are treating and their symptoms are not relieved, but we think that neurologically involvement is not much, and even if any confusion, we can always discuss with the other faculty and team members and refer them. And then during the follow-up visits, we are the one who generally get to see the follow-up of the patients every day after every treatment or whatever consecutive visits. So after every treatment, we get to talk to them about how their treatment goes, whether they have improved or whether they are not getting better or whether they have worsened. And we also can always talk about the psychological issues. Sometimes we all have experienced that most of the patient who has been there for a long time, who comes to visit us during their pain, they mostly become half family to us. They share everything with us regarding their family problems. And that's how we come to know them very closely and refer them if they have any psychological or biopsychosocial problems. Not working. Okay, these are the GSCI steps that Jeff Jove has already described. And here, why I'm taking this slide again is to emphasize what a non-surgical care provider can do in the provider third step, like care providing assessment. And the blue box that you have seen here in class 0 to class 1 and 2, these are the patients that we always deal with. And as you see, all the blue boxes, these are the maximum amount of patient that we come across of these spinal care problems. And the yellow class 3 are the neurological symptoms, classified under neurological symptoms. And we being responsible practitioners, we need to know the very thin line between minor non-progressive neurological symptoms and progressing neurological symptoms that has to be immediately referred to the surgical spine care providers or to other faculty. And the fourth one is the spinal fracture or deformity classification. Here also, if the spine is stable and there are no other with the minimal deformity and can be treated with the exercise, positional correction, stretching or anything, we can keep it to ourselves. But at the moment, we know that there are some unstable symptoms that are coming during our treatment, during the reassessment that we take the next day. As soon as we come across that, we should not hold the patient. This is our responsibility to keep the patient in the right place at the right time. This is why, again, I would like to emphasize why non-surgical healthcare, spine care providers are very important to take up this role. So GSCI steps has already classified and made some questions. All these yellow, that number 5, yellow questions are for segregating it to the neurological, if it is a neurological issue. Orange one is for the class 4 with spine fracture and deformity. All the red ones are the red flags that has some pathological issues. The answers that we get would let us decide to see if they have some pathological issues and that we should not be immediately treating them and refer to other faculties. And the 9th one is the pain. Pain is the major thing that we treat, which is involved with the musculoskeletal issues. And that is again divided into mild, moderate, and severe. And there are different steps that, and during this provider assessment, what GSCI model also says is this, all the assessment will be also done by a non-surgical care provider as well as the surgical care provider. So even the surgical care provider would know when to not operate and refer it to the non-surgical care providers. This is why all of us who are going through this, who want to be a better spine care provider clinicians, should incorporate in our practice for better results of the patients. So these are again all the classifications and sub-classification. I'll not go into this much. These are the flashcards. This will be discussed more in detail on Sunday workshops, like how after classifying or sub-classifying into different classification, how we can practice it in an evidence-based manner. This will guide us to be more evidence, do more of evidence-based practice. And always, after every treatment, what we always do is look for the outcomes. And if the outcome is all better, we can always reassess and send them back with exercises and modification, postural modification to the community. If they are only somewhat better or not better or getting worse, then we really need to stop. Like, our treatment should not be a dose of medicine that should be taken regularly at the same place, same phase, same time. Our treatment is always customized. We customize the exercise every day or the treatment every day, depending upon the worsening or bettering of these symptoms. And we take every decisions according to being a patient-centric, taking their feedbacks. So if the patients are only getting somewhat better with few sessions that you have done, or not getting better at all, or getting worse, then we need to stop and think if we need to change the mode of our treatment, if we need to do something else, or if we need to, okay, this is not going to help, I should not sustain this patient for long and we should refer it. Maybe there is something other to be ruled out. And also to see if there are any new spine issues that has developed again during the treatment process. So when we go through all this, what we realized is this is not something very new to us. As when I went through GSCI model, or when our friends who has attended the meeting, they have gone through this GSCI model, the guidelines, we have noticed that this is not something very new that we have never done. These are all the things that we have been doing, but with not the specific guidelines. So why GSCI model and National Spine Health Program is important for our country, I feel, is incorporating this in our practice will always make us practice in an evidence-based way, make us practice in a systemized way with the proper guidelines to follow, when to refer and when not to follow, when not to refer, when to treat and when to refer, and to put the right person at the right place. We will be better clinicians, making better decisions following the guidelines. And above all, also during 2077, Nepal government has again incorporated the basic health care package, healthcare service package in Nepal, which maybe in soon, nearly in future, that will be incorporated. And that has updated the list that musculoskeletal pain, disability, geriatrics, its management, management, counseling, proper referral, physiotherapy, and rehabilitation has also been incorporated in the government list. So more of the patients in Nepal, if this rule gets activated, a lot of patients will be getting free treatment in government allocated hospitals. And this is also why I think this is a very good opportunity that Spine Care National Spine Health Program is coming up at the right time, so we can practice it whenever there is wider range of our practice being explored in the country. We give the best service to the patient, being responsible practitioners. So concluding my presentation, I would like to say that interdisciplinary team, collaborating and working as an interdisciplinary team, teaching each other, learning from each other, and discussing will always be a profession, or will always be a practice of a patient-centered practice. And this will definitely help patients of our country and also to uplift all of our professions. Thank you.
Thank you very much, Dr. Niva Vajracharya. She rightly said that collaboration and interdisciplinary approach should be taken for the patient. It's because the treatment should be patient-centered. And National Health Policy 2078, as she has rightly pointed, that now it is a very comprehensive policy. So if we can collaborate, if our National Spine Health Program can be, it can be in the right place if we can approach the government for the National Spine Health Program. Okay, in the same vein, Professor Amit Thapa will be talking about the framework for the program, that is National Spine Health Program, if I'm right. So Professor Amit Thapa, who is president of spine chapter, current spine chapter.
Thank you, Dr. Neelam. Dear chairpersons and friends, well, this topic which I was given regarding talking about what is the general framework of the things which we are planning is basically the work of the whole team. We have been discussing over the past few months, and then we have come up a long way ahead. So I was just sitting and thinking what we have achieved over the last 7 months. And then we realized that the group, the 68 researchers from all over the world, they took 6 years to draft out this global spine care initiative. And here we are only 7 months down the line, and we have something coming up on our platform. So may I have my slides, please, Junaid? Okay. No, this was my first presentation. Can you put me the second presentation in? So, this was the talk which we had presented on November 27, 2021. So there were a lot of things which were discussed. We have actually come a long way ahead. And now we are talking about what framework could be feasible. So there were a lot of field visits and a lot of things which we have discussed over the period. So this meeting, which occurred in November 25, we had collected there. This was in Yakinyati, and then followed in which we had introductory workshop in March 7 and 8, which was participated online. And then we have discussion with Department of Health Services, security section, planning sessions. So a lot of inputs have been taken over this period. So what we are thinking is to approach this problem of managing the spine care in Nepal into two different patterns. One is a macro level, which is at the national level, and that is what we are planning work with the National Spine Health Program. And the micro would be much more manageable at a professional societies level, where we are trying to conduct an outreach clinic in Karnali. Then we have some implementation studies going before and after the intervention setup, which we'll be putting on Karnali, and looking at what outcome differences which we can achieve by putting on this philosophy of healthcare at micro level. And we are also planning to start masters in physiotherapy, particularly concerning spine care with universities, if in case it's feasible. So these are different things which we are planning and do different prongs. So the vision of the National Spine Health Program had been to ensure that everyone had access to the highest quality of spine care possible to the healthcare system in Nepal. This is very important for us to understand, because healthcare system is widely available in Nepal through the government setup as well as to the private-public partnership. And if in case, if the quality of the services which is provided to them is standardized, then of course everyone has an access to this. And the mission would be to provide a practical, evidence-informed and sustainable spine health model across communities. So what we are planning to do is to adopt GSI model of classification and the care models. And the philosophies, as my previous speakers has already said, right care at the right time by the right team in the right place. And why this motto is already been professed is that we all know acute problem is easy to tackle, but once the acute problem becomes chronic, particularly in the pain, then it becomes a pain for all, not only for the patient, but also for the system who manages that patient, because then the cure never comes in so fast. And henceforth, we need to train the people, particularly working as the primary contact for the majority of the public in Nepal, those are the community healthcare workers, into community spine health provider. So, and then keeping the term primary spine care provider reserved for that particular situation, where we will have a team of experts who are trained in primarily in spine care, but particularly from physiotherapist background. So if in case we can do that, then at the community level, when the village health worker sees a patient, they would have certain things in the mind to approach this patient according to a protocol. And then the subsequently non-surgical spine care provider and the surgical spine care provider, which the definitions my previous speakers have already said, can actually come along with it. Now, why we are classifying all these healthcare providers into these three terminologies is because we want to blur the margin between the different specialties. We are trained from neurosurgeon side, we are trained from orthopedic spine side, we are trained from physiotherapy side, there are chiropractors, there are occupational therapists. So there are a lot of people who are trained in managing certain portion of the spine ailments. we should not claim that we are trained in everything, but then we are trained in some proportion of the spine care. But then patient requires a wholesome care. And that's why if we can blur the margin between the different specialties and then classify according to these three simple classification, it makes the life very easy to classify and to refer the patients also subsequently. And also when we use a single model of care, then it will be easy because the language we speak will be understood by each of us. If somebody says category 4, category 5, we know what we are talking amongst each other. But if in case somebody will say facet arthropathy or there is some other problem like subluxation, then only few of us or in the whole team of healthcare provider who are actually the primary care provider in villages may not understand these terminologies. So that's why it's very, very important for us to use simple terminologies at our places so that people can understand what language we are talking about. And henceforth, we strive to create a proper referral system by training the primary caregivers so that we have the largest approach, largest reach to the public, as well as enrich our current spine fellowship program. Even a spine fellowship program, which are surgically oriented, they have very little place for conservative care and the rehabilitation program. So we need to put some period of exposure to these people also. And also train our allied specialties so that the allied specialists also understand the surgical specialists as to what we are talking when we're taking about care of these patients. And also help in developing a national registry for spine problems, generate database and improve research, and use evidence-based practice in spine care. Now, we have a very well-defined public health system in Nepal, both working at the community and the regional level. What we want to do is train the community health worker into the approach laid down by the Global Spine Care Initiative so that we can actually get to the grassroots level and can create a good referral system. Now, primary health care is the key to the universal health coverage. This was the term which was coined in 2019 by World Health Day celebration in matter of providing a universal health coverage. And henceforth, PSC always plays a role here. We have a doctors there, we have a good well-trained health staff. They can also be trained in these protocols. So Global Spine Care Initiative, which comes very handy to us because it's already an evidence-based program laid down. What we are planning to do is we are trying to adopt this program into the Nepalese scenario because nothing can be copycat in our situation. Our situation is very unique and henceforth we need to draft in a very modified manner. And then once we actually adapt it, then we can actually go for a review and then refer. Now, Nepal is very different because of its unique geography, unique psychosocial needs, unique working environment, and even unique healthcare delivery system. As Dr. Bimal just said, that our pharmacies sometimes work, not sometimes, but most often times works as a primary care provider in the urban as well as in the rural setup, which we haven't ever considered. So that's why we need to consider those elements also. So over-the-counter drugs are very fairly easily available in Nepal, and that's what the people actually keep on taking these medicines and stay at home rather than taking other preventive measures to avoid the problems coming up in future. So what we are trying to do is to make 3 co-working groups, including all stakeholders, and then try to make a plan, a draft, so that the spine health program, what we are trying to do should be taking all the elements into consideration, modify the GSI model. If you see the GSI model, it is still very complicated. The sub-classifications, the categories they discuss, it is not very easily doable in the community setup. So we need to cut down most of it. And Geoff and Andre have actually come up with a very simplified version. So those 10 questions which you just saw was the recent work which has come as a modification of GSI. So we are still planning on that. So these are many things to draft. There are many things to plan now. And as the planning and drafting goes on, simultaneously, we can have a committee which can actually make a plan to how to train in this GSI model, because all those play card system, all those diagram system, which Geoff has made in his presentation, needs to be taught in a very primary language, need to be Nepali Karan Bhansani. So we have to convert it into Nepali so that it becomes a lot more easy for people to assimilate it into their practice. And at the same time, we need another arm to see whether the implementation of these things are going in a correct manner or not. So the execution and implementation part is something else we need to consider. So these 3 working groups can actually help us in taking the things forward. At the micro level, just a brief talk. So an outreach clinic in Karnali is being planned, and Karnali Academy of Health Sciences is helping a lot in this. So recently, Geoff and Andre had been in Karnali together with Dr. Neelam, and they have done a field survey and have come up with a very good plan, as well as some MOUs, I think, is supposed to be signed. So then in case that happens, then our first outreach clinic can be started as soon as possible. Now, this outreach clinic will also serve as a training center for the physiotherapists, as well as for other volunteers who want to go to the micro level, to the villages, and see how this program can be run. And then to study the effects of implementation of this project, we have already submitted a collaborative project titled Evaluating the Readiness and Feasibility to Implement an Evidence-Based Model of Spine Care in Rural Municipality and a Tertiary Facility in an Urban Setting in Nepal, a Global Spine Care Initiative Implementation Project, details of which will also be told by Dr. Andrew in his presentation. So there are a lot of things which we are actually planning, and we are in our phases to do it. But then the big question is how to make the program sustainable. We are still in a very, very nascent form. We are still in the planning stage. And that's why there are a lot of things which are still unclear. And that's why we need the ownership of Government of Nepal and Ministry of Health and Population to take the leadership and see this particular program go through. We have already understood that is required, and we have already comprehend that it is doable. It is nothing which is a very Herculean task. Only thing is some amount of coordination and leadership is required to pull the things together. And then there are a lot of professional organizations which I can see they're very much willing to give their time and energy into this project. So things are everything there. So we have a fire, we have a things to burn, we even have a good environment where the fire can take place. So there's nothing else which is required, only a good leadership and an ownership. If in case goes along, then this particular thing can be kindled a long way ahead. And then of course in the education sector, we are talking with the universities, if in case we can put it in a small section into the undergraduate programs, as well as in the postgraduate level, when we start to train some spine specialists. And then similarly, training programs are required for primary spine care providers or community health spine providers to start with. And also the trainer program sessions are very much required to go into it. And feedback cycle is ultimately required so as to drive this program into right directions by giving feedback at the right time. So with this, I would like to conclude my presentation. We had a lot of discussion, which actually occurs at 10 o'clock in the night in Nepal, just to keep track with the international partners. But then even though we were sleeping, most of us are sleeping during the talk, it seems. But then our brains are still active, and the fire is kindling in our heart. We want this program to take its shape as soon as possible so that we can all become a force to reckon with. Thank you for your patience listening, and I will be open for questioning.
Thank you very much, Professor Amit. Talking about the timeline up to till now, where we have come for the National Spine Health Program. And the next presenter is Dr. Andre Busia. He is also from World Spine Care and expert in research implementation. We'll be talking about measuring the effectiveness of the program. Dr. Andre Busia.
Good afternoon. Thank you very much for the invitation. It's really my pleasure to be here today and be able to discuss with you how we could potentially implement the model of spine care in Nepal and evaluate throughout the micro and macro level the success of the program. So if I could have my slides, that would be wonderful. We had the privilege and opportunity to visit Karnali Jumla, and more specifically the municipality of Guchikar in the recent week. And this was extremely important for us to understand the context by which patients are seen, managed at the local level. We also are fortunate to have collaborations with our colleagues at Kathmandu Medical College. And so what I will be discussing today is essentially thinking of the model of spine care, where we have discussed the classification system already, the flashcards, which are basically guidance for clinicians to make informed decisions about where and how best to manage the patient at the different classification that was mentioned. think now of this as a program, which is quite complex, has many, many fields, many different people that are involved at different times. And we need to now consider how we're going to implement this at the micro level and at the macro level. And how do we evaluate the success? So without further ado, and I would like to acknowledge all the collaborators on this effort. And this is part of the work that we have submitted to the University Grant Commission and hoping to be successful. This is a 4-step process. The first one has been discussed already, the creation of the model of spine care. And we're now going to go into the specific customization and pre-implementation and talk about the feasibility to implement this model of spine care in Nepal. And lastly, at the 4th phase, learn from all these different studies to be able then to have a large-scale sustainability impact study in Nepal. The model of spine care, as we now understand it, and is being slightly modified, tailored to the need and the system that is in place in Nepal, will then be implemented as follows. It requires to have effective implementation strategies. The literature is very rich in understanding what seems to work at what level. By level, I mean targeting the decision makers, the policy makers. We require extremely strong engagement at all levels for this to be sustained over time. We require strong engagement of care providers as well, at the community level, the secondary and tertiary care level. Patients themselves, who are going to be managed and will have to learn about self-management. All of this therefore requires to be contextualized. The Medical Research Council provides this framework for us to understand a little more how we can go about to implement. Right now, we're in the red box. What we're thinking about is looking, of course, at the context. We're thinking of developing program theory so that we understand when we do something at one level of the healthcare system, how does it impact the outcomes? We need to think about uncertainties, the challenges of doing so, and refine the different strategies we'll be talking about in a few minutes and think about the economic impact. This is an iterative process that we then would like to think about the feasibility as phase 3 of implementing the model spine care in Nepal in 2 regions, a rural community and an urban setting, and then measure the impact. So what we first need to think about in terms of purpose is to explore the readiness of the model spine care to be implemented within these 2 regions I just mentioned. We need to confirm the magnitude of the problem. How big is this an issue? How does it impact the community and people that have spine pain? What is the perceived value of the stakeholders, meaning decision makers, the clinicians themselves, the population, the residents in the municipalities, and whether there are challenges that we need to think about and improve on the solutions that we would like to use to implement the model spine care. The 2 areas is the large urban setting here in Kathmandu Medical College, as well as the area that the rural community we were able to visit for a week in Kuchikar. Why? Because it's one of the far remote regions of Nepal. It is difficult to access. It is currently underserved and absolutely beautiful to visit. The design is called a mixed method approach, where we measure both quantitative and qualitatively using a participatory approach. Participatory approach is absolutely essential for models of care like this to be adopted. This is where people collaborate from all the different levels I spoke about for this to be sustainable over time. We need to think of this as a stepwise approach. We need to learn, prepare, understand the context, plan, and design suitable implementation strategies that we will test in future studies, which is the phase 4 talked about. We would like to include adults with spine concerns and pain, the caregivers at the different levels we talked about in those 2 settings, including municipality leaders and decision makers and policymakers throughout. The goal is to customize, prepare the implementation, And therefore, and I'll repeat this several times, stakeholder engagement. And we need strategy to do so. We collect information from the Community Health Survey, which is an orally administered survey going door to door in the community and asking, does any one of the adults here has back pain or neck pain? And how do they manage their problem? How important is this? And how disabling is this? We'll have chart reviews in the facilities, healthcare facilities, to understand what is currently being done for these patients. How are they managed? And interviews, understand the perspective of the different stakeholders I mentioned about the model of care and how they see the context and the need to adapt this. The data will be analyzed and further adapt, both for the classification system, the flashcard that Jeff mentioned, as well as the implementation strategies. We need to also think of this as a multidimensional approach to evaluation. The program is on the far left, model of spine care. The implementation strategies have to target all the levels I've mentioned again. There are, as I said, a number of systematic reviews and meta-analysis about the effectiveness of different strategies, but are they perceived to be useful, applicable in the different contexts where we're going to implement this? Outcomes of implementation are those where we're purposely and intending certain actions to be able to integrate the model of care into different contexts. Service outcome is what care providers do on a day-to-day basis. Clinical outcomes would be those of pain, function, disability, and quality of life we would measure at baseline as well as after the implementation of the model of spine care. This leads us to the third phase, which includes then the likelihood of being able to integrate the model of spine care in those two communities at all levels, and then measure the potential impact it has on the patients themselves and on the community. So let's imagine we have a patient, comes in with back pain. He's being seen by perhaps a community health worker. It could be a provider, clinician with good training, could then decide whether this patients need to be sent for urgent care, or we move on to further assessment. Trained clinician can provide the full history taking, appropriate physical examination, and recommended care for this patient. We therefore can measure at each of those steps what is being done, how is it being done, and what is the impact of this doing. And ultimately, patient would be either discharged, they're doing better, and they're self-managing, or they need further evaluation and treatment because the pain is ongoing. Or last, they need to be seen by a healthcare specialist because the problem is not improving or getting worse. The plan is therefore to administer a number of different tools, instruments, validated questionnaires, and again, run interviews and see how people have experienced, have changed as a result of the implementation of the model of care. And we'll do further adaptation if needed. These are measured at the decision maker level. We have measures for the clinicians themselves, for the patients, and for the community educational program that we're intending to implement as well. And so this is done pre and post implementation, and essentially over a 2.5 year period, we would be ready then to be thinking about the next phase. This means that we will have learned about the community needs, the community interest, and the perceived usefulness from those two very different regions, the rural community and the urban community. Therefore, we're left with, hopefully, a culturally acceptable model of spine care that is seen to be very useful, that it fits with a gap currently that is identified as a need. The next phase would therefore be to then think nationwide of scaling up and implementing the model of care in the different provinces. Reaching the four main aims of the model of care would be to improve patient health, improve the experience of patients throughout, the experience of clinicians, and finally, to be able to improve on the way in the access and the cost reduction and efficacy of the healthcare system as a whole. We think of randomized controlled trial as being the gold standard for treatments. We compare on the left-hand side, one treatment versus another. Does this work better? Is it cheaper? What we're talking about here is a very complex model of spine care. It's a program, and therefore implementation research is rather on the right side and more in the natural environment. What we need to do then is think of something that's quite pragmatic as a design, that is flexible and dynamic to the healthcare system, that respects the local context issues and is meaningful to the end users. There are a number of different types of research designs we can use then to study whether this is indeed effective, cost effective, and actually made a difference to people. So very briefly, using this pyramid, we can think of measuring impact at the practitioner level and the patient level and the community level. Was there, for instance, appropriate use of advanced imaging? Have clinicians systematically used patient report outcome measures and patient report expectation? Have patients self-manage appropriately? Was the model of care used with fidelity? Have value-based care? The access is improved, the resources are used in terms of cost and people as effectively as it can, and there's benefit and efficiency and sustainability. Over time, this pyramid will reverse, and the system level measurement will become more important as data can be collected systematically throughout the system. Together with stakeholders, the decision makers, the policy makers, the clinician, the end users, we need to think about the important things we need to measure to determine whether this is successful or not. There's a continuous improvement process. I mentioned it needs to be pragmatic. We need to have a quality assurance program. We need to have systematic data collection. We need to be able to determine what are the key indicators that are going to say, yes, this is working. We're happy with the results. And the engagement of participants, and lastly, the uptake of integration. I would really to acknowledge the numerous people that are working on this program, the collaboration we've received and the welcoming, the funders as well, and hopefully the University Grant Commission, we're hoping to receive good news from very soon. Thank you very much.
Thank you, Andre. That was a very good summary of what all implementation projects we are thinking about. And next in line, we have again Geoff coming to the stage. We invite him to talk on WSC experience and outcomes.
So for 10 years, I was I still guess I am the clinical director of World Spine Care. So my role was helping to set up programs different from the one we're working on here in Nepal, but different clinical programs in different countries. So we started in Botswana, where I lived for 2 years with my family to set up our flagship clinic. And then we moved on to other countries. You guys getting tired of that picture? What I want to talk about is World Spine Care. So we've heard over and over again about the burden of spinal disorders. Don't have to reiterate that, but our organization, World Spine Care, is the only organization that's really tackling this health crisis in an interprofessional, evidence-based, and sustainable way. The mission of World Spine Care is improving lives of people in underserved communities through sustainable, integrated, evidence-based spine care. We are registered as a charitable organization in Europe, Canada, and the United States. And we're endorsed through the World Health Organization through the Global Alliance in Musculoskeletal Health. The one presentation we missed by Deb Kapansky-Giles has a whole list of how World Spine Care has been endorsed and accepted by the World Health Organization. So I'll just leave it at that. So eventually we had 4 programs going, in 4 countries. We attempted to set up programs in other countries like Ethiopia and Tanzania, but a lot of elements have to come together for something to actually work. As Andre is talking about stakeholders, we need the right stakeholders, we need the right funding. And it doesn't always work in every country. But we did manage to set up 4 programs and have 7 clinics running in Mocha, Dominican Republic, Accra in Ghana, Shishong, Mahalape, and Habaroni in Botswana, and Navi Mumbai in India. So I'm going to go through each of those. So Shishang, Botswana was the first project we set up. And we actually set up a physical clinic in a rural village, very much about as rural as where we just were. And the idea was to set up a clinic where we were actually providing really high-level spine care. So we had the primary spine providers, the spine specialists, that was chiropractors and physiotherapists with advanced training in spine, who were running the clinic, because we wanted to see if we went out there and we did that, how do we need to modify what we do? What can we learn from these communities so that we can be more effective at delivering care in those communities? And can we be effective? So we had a whole data collection process where every patient, we would enter data in a spreadsheet, and I'm going to show you some of that data afterwards. So this was what we were trying to do, and doing that in multiple clinics. So that was a primary care setting. 40 kilometers away was Mahalape District Hospital, and this is where we actually physically live, not in the hospital, but in Mahalape. So this was a secondary care center, and we had a primary contact spine care clinic inside the secondary center. So again, chiropractors and physiotherapists with advanced training were running this clinic. Patients would often go through the orthopedic surgeons or the medical doctors and be referred to us. Or after a while, once everybody got confident in what we were doing, they just started sending patients straight into us to, again, take away that burden from the surgeons and the medical doctors who were dealing with all kinds of back pain, neck pain, headaches, and so on. So this was a primary care clinic in a secondary care setting. And then we eventually, and I don't have a slide of it, but we eventually moved into the main referral hospital in Gaborone in Botswana and set up, again, a primary care center inside now the tertiary care hospital. And lots of patients were referred through the surgeons, spine surgeon. Actually, at the time, they did not have any spine surgeons. So through our organization, we set up a fellowship for one of the orthopedic surgeons to train in spine in Turkey, and he then returned and sort of became part of that spine care team. Then we went down to Mocha, Dominican Republic, and this we had set up again, primary contact clinic run by chiropractors and physios with advanced training inside a rehabilitation institute associated with the Mocha District Hospital. And this Dr. Haldeman, who you just listened to in the presentation, and Dr. Tavares, who is part of our team in the core working group for World Spine Care and the National Nepal National Spine Care Program, and then Dr. Eberspeker, who's also been involved in helping with some of the work with this program. In Accra, Ghana, the clinic it's actually a medical doctor who's also a chiropractor, so a lot of training, very good with spine, and she was running a primary contact clinic inside the outpatient department in the Ridge Hospital. And then at the Mahatma Gandhi Mission University of Health Sciences in Navi Mumbai, it's a large physiotherapy program. And the physiotherapy clinic is inside the hospital. And so part of the physiotherapy department, there's a World Spine Care division. And so the physiotherapists will go through and do spine specialty training within that. So now we sort of have a generation of physiotherapists graduating from this program who have more advanced knowledge in spinal disorders. And have any of the physiotherapists here been to the Mahatma Gandhi Mission University? Okay. And that program is still going on, and that is one of the other sites we're looking at implementation. So from these clinics, I'm going to show you the outcome measures that we use, because we wanted to know where we actually getting patients better. The first, the one is the Wong-Baker faces, and basically a pain rating scale. I'm sure the physios are familiar with the Wong-Baker faces, but we had to modify it because some of the terminology and some of the stuff we were looking for outcome measures that could be implemented in low literacy populations. And that becomes difficult. You've seen all the outcome measures that you've used. A lot of them are either not relevant in a rural community because they're set for people in cities. They're talking about getting off and on buses and going up and down stairs. When you're in a community where there are no stairs or the people don't use transportation. So we had to do a lot of modifications. And one of the other ones, so activities of daily living was very difficult, but we did strip it down to the types of activities that everybody does all around the world all the time. You get up and out of bed, you walk, you sit, So it was wrapped around that. But the other more important one was the patient-specific functional scale. As a clinician, we walk in and we say, okay, what can't you do because of your pain? And the patient tells us. When they come into the second treatment, we ask them, well, can you do that now? Or are you still having difficulty with that thing you couldn't do before? So the patient-specific functional scale is just an outcome measure that does that. What are the things that you can't do because of your pain? Rate them on a Likert scale. And every time they come in, they reevaluate how they're doing. Can you now do it more easily? Can you do it completely? Are you still having difficulty? And then the last was a brief depression screen. So the data that I'm going to show you is using these outcome measures. Having the same problem Neba was having with the, okay, how do I go back? There we go. Okay, so just in terms of demographics, these are fairly consistent with what we see worldwide. Usually more females. Mean age is in sort of 40s and early 50s. The percent serious red flag pathology, you'll see 13, 9, 12. That's pretty consistent. That doesn't mean those are surgical cases, but those are red flag pathologies that needed to be referred to secondary and tertiary care. The percent of patients that presented non-specific pain was quite high. Most of the patients walking in. This is what we're saying. 90% of the patients that come into, that have spinal pain are presenting with non-specific pain that can be managed at a primary or a non-surgical level. You'll also see that the percent serious red flag pathology and non-specific pain, they don't always add up to 100 because sometimes it's a specific pathology that isn't a red flag, like a radiculopathy is a specific pathology, but it's not a red flag referral. And then the percent of the patients coming in where their first complaint was low back pain is also quite high. And then the number that are coming in that their primary complaint was spinal pain, not just low back pain, but any spinal pain was quite high. Now we were World Spine Care, so maybe that was why we had a little bit higher numbers in spinal disorders. Also patients, the vast majority were chronic pain. That's over 3 months. And also the vast majority of that pain was interfering in something in their life. Okay. So then we treated them. And we looked at the average number of treatments to therapeutic resolution, and we were around 5, 6, 7. Okay, and sometimes that therapeutic resolution was this person is going to have to be on maintenance care because they need continuous care on a regular basis to maintain their quality of life. We can't do any better. Sometimes that resolution was we got to refer you to surgery. So it's just average number of treatments beyond the initial visit to some sort of a decision on what to do long term. So the percent that had clinically significant reduction in pain, and through the research, you'll see clinically significant, maybe anything between 20% and 30%. We thought we were going to use 30%. And so the vast majority of patients had a clinically significant reduction in pain, even more significant improvement, increase in function, and then percent with clinically significant increase in activities of daily living. So remember, reduction in pain was the Wong-Baker faces, increase in function was the pain-specific functional scale, clinically significant was the ADL questionnaire, and then the reduction in that brief depression screen. Now, these numbers are all numbers we collected with patients that we got a final outcome from, but you could see about 40% of our patients would just self-discharge. And then we'd have to chase them down and try to get some answers. And of those patients that we got answers from, you can see the 61% in brackets had clinically significant improvements, 54% clinically significant, 50% clinically significant, which means that all of these numbers that you see above are based on the people that we didn't chase down. But when we finally chased them down, these numbers even got better. So what we got out of this is that if we have really well-trained spine specialists out in a primary care setting, whether that primary contact setting, let's say, whether that's in a village or rural community, a secondary care facility, or a tertiary care facility, those primary spine care specialists, those non-surgical specialists who have advanced training in spine, can have a really great impact on the outcome of patients. And if they're really good with their triage and their decision-making and they're monitoring the progress of the patients, they're going to make very appropriate referrals of when they need to go to a surgical consult. So the surgeons don't end up seeing all kinds of back pain patients that they are just going to have to shuffle back down to the primary contact. So that's what came out of our clinics. Thanks again.
Thank you, Geoff, for a very lucid presentation on your experiences over these different countries. So we see this particular initiative had been there in many countries, and even in Nepal, the thirst is giving but much more deeper. Now we will have Professor Paulo Pereira. He will be speaking all the way from Portugal, and he is basically presently the General Secretary of the Spine 20 initiative. Spine 20, it's a group of G20 countries who are into this sort of program. And he will be talking on Spine 20 initiative. So can we have Professor Paulo?
Thank you. Can you hear me?
Yeah, you are audible, Paulo.
Okay, perfect. So let me share my screen. Okay, I believe you can see it now, right?
Very well.
Perfect. So my name is Paulo Pereira. I'm a neurosurgeon fully dedicated to spine from Porto, Portugal, and professor of the Faculty of Medicine of the University of Porto. But I'm presenting here on behalf of the Executive Committee of Spine 20, and we'd like to start thanking the organizing committee, and particularly Professor Hamid Tapa, for the kind invitation and the opportunity to present the Spine 20 initiative in this forum. So what is Spine 20? So Spine 20 is an advocacy group involving international societies who strive to optimize spine care on a global level by creating recommendations on health policies at the G20 summit. So our mission is to optimize treatment in the global community to ensure patients have access to the best spine care possible in their respective regions, envisaging a world where appropriate spine care helps minimizing global disability and dramatically improve the lives of those suffering from spine problems so their families and communities can thrive. So how can Spine 20 help governments to alleviate the burden of spine disease and disability? Serving as a research in spine-related healthcare and prevention, advocating for the prevention of spinal disorders, advancing spine research, stimulating innovation, and facilitating access to spine care and treatment to improve function and decrease disability of these patients. And how can we influence change? So by creating policy recommendation, establishing a legitimate connection to the G20 group, and leveraging global connections. And who are we? There are 4 founding societies, which are the German Spine Society, Eurospine, the North American Spine Society, and the Saudi Spine Society, and 10 other societies join it as partner societies and are members of the Spine 20 Advisory Board. And we welcome all societies or journals interested in spine-related disorders to participate, discuss, review, and endorse our recommendation. This is the organization of Spine 20. The executive committee is made up of representatives of the 4 founding societies and of the host societies of past and future Spine 20 G20 summits. The chair of each annual meeting is responsible for the communication with the G20 Sherpas and the official G20 groups, reports to the Spine 20 Steering Committee, and coordinates the annual meeting task forces. The preliminary plans of Spine 20 were set in a meeting with representatives of the 4 founding societies during 2019 Eurospine annual meeting in Helsinki. And the follow-up workshop was organized 3 months later in Riyadh. Then COVID-19 pandemic arose, but the founding and the partner societies kept working together to organize the first annual meeting to be held in Riyadh in November 2019. This is how Spine 20 works. So there was a steering committee for Spine 20 meeting in Riyadh. Then a scientific task force designed the program for the meeting. The publication and recommendation committee task force created recommendations that were published in the European Spine Journal. And then the same circle for Rome with the steering committee, the scientific task force creating the program, the publication and recommendation task force creating the recommendations that have just been accepted last week to publication in European Spine Journal again. And we keep working on that for next meeting we're gonna be in Bali. So for each annual meeting, spine-related domains are selected and symposia are planned according to these domains. Spine 20 annual meetings are summits with the participation of individuals and organizations. So the challenge for Spine 2020 in Riyadh was the execution of the defined plans. The theme of the meeting was ensuring access to quality spine care to prevent disability throughout the world. And 8 symposia were organized. These were the team members for Riyadh. These are the 8 symposium, and 2 sets or recommendations were created, a full pack of recommendation and an executive summary that were sent to the G20 representatives present in Riyadh through the Sherpas. The challenge of Spine 2021 in Rome was to prove the continuity of our plans. So the topic, the theme was care for pupils' health and prosperity. 6 symposia were created. Again, these are the team members, the 6 symposium, the 2 packs of recommendations. And these were the countries from which we had individual participations, and we see the partners and the endorsing societies and 2 endorsing journals that were Global Spine Journal and European Spine Journal. So next meeting will be in Bali in August this year. After learning from previous meetings, we made our organizational process more structured and efficient, with a well-defined timeline for the scientific and the publication and recommendation task forces. We are now finalizing the program, so we are in the middle of this process. And as usual, the theme was defined by the local host, but to strengthen the methodology, we implanted the Delphi method to select the domains for the symposium that were chosen by at least 75% consensus between the 21 experts who participated in this session after 8 rounds. Lastly, the subdomain of each symposium was decided by the co-chairs. Hence, 6 domains were selected during the Delphi session, and a 7th domain was decided by the host country. In 2022, we also decided to include education as a permanent domain, and that the corresponding session will be organized by the education committee. According to the available places, it was decided that each founding society had the right to nominate 2 co-chairs, and the partner societies and the next host countries 1 co-chair each. You can see on the right table the chairpersons nominated by the different societies together with their symposium preferences. The theme for Bali will be spine care, work together to recover stronger. And you can see here the domains, subdomains, titles for each symposium together with their chairpersons. We are delighted that we'll have the privilege of having Professor Amit Thapa as speaker and panelist on the Access to Care Symposium. So we believe that Spine 20 represents a disruptive approach, aiming for global engagement, reaching out to stakeholders, and delivering recommendation to G20 concerning spine care that can promote excellence in developing countries and capacity building in the underserving communities. Thank you very much for your attention.
Thank you, Professor Paulo. Next, we'd like to welcome Dr. Rudra Marasani. He is going to talk on next steps for the National Spine Health Program. Dr. Marasani, he has worked in Government of Nepal in various capacities. Yeah, Dr. Marasani.
Thank you very much, respected chair, co-chair, and all the delegates. Thank you very much for inviting me in this prestigious forum. Today, I'm talking on behalf of Director of Management Division, not as an orthopedic surgeon, not as a spine surgeon. Now I'm working in the public health sector under the Ministry of Health and Population as a director in the Department of Health Services. So I have very short presentation and just I will find out the way how we can initiate this national spine program in our national program. I just want to share that only. Sorry. Now, why the spine health program is not a priority program of government of Nepal? I just want to highlight our priority programs are communicable disease. Yeah, sorry. I just want to. Okay. Spine health and rehabilitation is a neglected part of the hospitals and the government as well, because we are not working a lot in these fields. And there is no comprehensive spinal injury management center in Nepal, except few centers in the private and community level. Government doesn't have comprehensive center, and even the private hospitals, they are very beautiful. We have very beautiful private hospitals, but they have not a comprehensive spinal care rehabilitation center. The reason is this may be it's a neglected part. I want to say this is a neglected part. So there is no even single center, spine center in the government also. We have lots of orthopedic hospitals. We have lots of central, regional, and provincial hospitals, but no specific dedicated spine centers. So, in the other priority programs, government of Nepal is spending lots of money in the other programs like infectious diseases, communicable diseases, tuberculosis, HIV/AIDS, Kala Azar prevention, even polio, and they have spent lots in the maternal and child health, reducing the maternal mortality, neonatal mortality, community-based IMCA program, and even the donor agencies. We talk about the World Health, WHO, even USAID, and all the donors. They are working only in these programs. They are investing in HIV/AIDS, communicable diseases, wash and hygiene, all those things. But they are not investing in our spine care and this burden. So we have to create a awareness why this is important and why this has to be a national program. That is the main challenges for us. And we are working on achieving the sustainable development goals. And there are, all of us know that there are 17 components. None of the components includes this spine and other rehabilitation service. That is also very, I can say this, again, this has been also neglected from the national as well as international level. This is not a priority program. Okay, I'm not talking about this in details. And we have lots of work has to be done in the spine health and rehabilitation services. palliative care, occupational health, and the comprehensive trauma services. Even we have trauma centers, we have beautiful private hospitals, well-equipped hospitals, but trauma care, there is no comprehensive trauma care. We are doing lots of advanced surgeries, but the service is not comprehensive, and the poor peoples are not getting this very easily. So we are doing spine, it's very technical and sophisticated spine surgery. And you see, Nepal Orthopedic Association, there is a lot of colleagues. I'm also orthopedic surgeon, and a lot of colleagues are operating in the spine. There are Association of Spine Surgeons, there are a lot of spine surgeons, and Neurosurgical Society, which we are talking right now. There's a lot of people who are working in the spine services, but we have not worked enough in the rehabilitation services, and we have not given this is a priority. So this initiative, Dr. Amit and the NESON, National Society of Spine Surgeons, you have, I would like to congratulate you. You have started this initiative, which is a neglected part and not a priority program in our national health program. And this is the only one rehabilitation center, I say comprehensive rehabilitation center in the Nepal. That is the Spinal Injury Rehabilitation Center, Saga. There is not, still we need to have at least 5 to 7 comprehensive spinal rehabilitation center, at least one in one province, I say. But we didn't have, even in the single center, not in the government level. Okay, spine surgery, doing spine surgery is not a spine care, because spine surgery is a very small part of spine care, I say. Doing the bad surgery is rather than not doing the surgery. Doing bad spine surgery is better than not doing the surgery. See, this patient is suffering. How much this patient suffered? So this is this patient is having cervical myelopathy of JOA 70, at least a complete cervical myelopathy, JOA grade 15 up to. And see the status. She has been operated, but how surgery? What type of surgery did it? This type of surgery, doing the surgery is bad rather than not doing it. So, and what we are doing, and we have started little bit in spine care. Government has initiated the social security scheme for the spinal injured patients. We have started. We are giving 100,000 Nepalese rupees for the treatment as a social security program. Once the patient got injured, we are providing 100,000 rupees for the treatment as well as rehabilitation services. So to include all the publics, all the poor people can achieve, can get the free treatment. That is the motto of this 100,000 rupees, Nepalese rupees, for the surgery as well as rehabilitation purpose. But in this program, most of the private hospitals are not listed. This is very bad news, I say. Most of the government hospitals are listed and community hospitals are listed, but most of the private hospitals are not listed in this package. So I would like to request all the private hospitals, please use this initiative and try to give the service by using the government fund and treat the patient freely, so that we can treat the patient freely. And we have also initiated at least 5,000 rupees per month for the spinal injured patients as a allowance. Spinal injured patients get 5,000 per month as a allowance in our national health, in our health program. So these are the social security schemes which we have initiated for the spinal injured patients. And the spinal rehabilitation and the palliative care has been included in the national policy of the government in fiscal year 79-80. This year, because I'm working in the Department of Health Services, and I'm proudly say I'm talking about this rehabilitation services should be a priority program. And I am raising this issue many times in ministry as well as in Department of Health Services, so that we have able to include this rehabilitation and palliative care service should be the priority program of government. And this has been included in the coming fiscal year program. And Niti Tatha Karyakram, in Nepali we used to say this Niti Tatha Karyakram, which has to be endorsed from the parliament, and this has been included in this year's Niti Tatha Karyakram, and so that it becomes a priority program from subsequent years and subsequent months. What next? We have make a concept of at least one comprehensive trauma center in one province, which includes the spinal services also. And this has been approved by the government, and feasibility study and detailed project reports has been works has been done in this concept. This one trauma center, comprehensive trauma centers, which includes the services of spine as well as other type of trauma. This has been approved by the government last year, and the feasibility study and DPR is being done. And that we are also making a comprehensive management of spinal injured patients program as a health package. In this, the annual budget and work plan, AWPB, we say annual budget and work plan. In the coming years, annual budget and work plan, we have included comprehensive management of spinal injured patients, a training program for the health worker. And this includes the training of the physiotherapist, training of the nurses, and the training of the medical officers who are working in the remote areas. And we are also working on the rehabilitation and palliative care centers. At least one center should be in one province. This is under discussion, but these have not been finalized. And this is under, we are discussing, we need to have at least one rehabilitation centers in at least one provinces, which center would work exclusively on the rehabilitation of the spinal injured, as well as other stroke patients, spinal injured. There are lots of patients who are not getting the rehabilitation services. So, and from the coming year, we have also planned for the national treatment protocol for the spinal pathology. All the spinal pathologies, we wanted to prepare a national protocol in the Nepalese language, simple language. This work is initiated by the Curative Service Division, and that training will be conducted by the National Health Training Center, NSTC. So I am very happy you have initiated the National Spine Health Program. So let's work together. Let's put this in our national program. Let's make it a priority program, and let's work together. That's what I want to say. And from the next year, I'm hopeful that we will create the protocol. It's Nepalese language, very simple language, to be understood by the medical officers, paramedics, and nurses and physiotherapists who are working in the rural areas. Then it has been gradually, this will become a priority program. That's what I'm thinking, and I'm talking with our secretaries and our director general and other planning peoples in the ministry. Let's see how much we can do, but we have to be very positive, and we have to work on the spinal pathology, treatment of spinal injuries, spinal pathologies, and mostly the neglected part. I always say the neglected part is the rehabilitation services. So thank you very much. Thanks for inviting me. Thank you.
Thank you, Dr. Rudra. We can appreciate the initiative that you have taken, being a spine surgeon. And obviously, you must have worked hard so much to include this rehabilitative service in our national health program. Now we come to the end of the session. So this is question and answer session. Professor Amit and Professor Scott will take over now.
Thank you, all the speakers. Zonet, can we have all the panelists on the screen, please? Yeah. So the session is now open for any queries, and you must have listened to the talks. So this deliberations have been made from personal viewpoint and a lot of deliberation amongst their own members and societies. So if somebody has any query, please ask, and then we will try to sort it out, and maybe we can have a lot of feedbacks from you all so as how to run this program much better and take ahead.
I'd like to just make one little comment. I'm extraordinarily impressed with this program. And a couple of the papers really brought up stuff we have to think about. Dr. Pandey basically illustrated that the problems we're facing in the high-income countries, namely just marked number of treatments with claims of success, is inherent in the police system as well. The second is the report by Dr. Pereira. This Spine 20 program is probably one of the most important programs out here this year. in the last couple of years. And World Spine Care is proud to be part of that. If Dr. Kapansky-Giles had managed to get her program together, she would have talked about the World Health Organization international guidelines on back pain, which is currently being developed, as well as a number of other programs. And then finally, Dr. Morosini actually showing some changes is such a promise. This is not a Nepalese problem. This is a worldwide problem. And we're all trying to come together wherever we are in the world to try and help those people who are so far being neglected, and despite their disability and abnormal quality of life. That's the only point I wanted to make. I'm very pleased to be here.
Dr. Paulo, you want to say anything?
Thank you. Thank you very much. Yeah, I'd like to stress what Professor Heldman just said, that this is really a global problem, and when we are, it's very important to have this effort in the underserved communities and poorer countries such as Nepal. But a lot of money is in developed countries. A lot of money is wasted in appropriate care in spine-related disorders, and this is why I really believe that it's very important that physicians and non-physicians and clinicians who treat these patients came together and group around the supranational initiative, so that we can tell the government and the people who are in charge, who have to take the decisions about the immensity of this problem. As Dr. Morosini just said, it's really astonishing that being the spine disorders, the ones who are contributing more globally to the disability, to the years lived with disability of the population, so little attention and concern is given by the governments to this problem. And I really think it's our mission to come to them and to deliver to make our voice heard among the appropriate institutions and to involve the stakeholders in this decision. Thank you very much for the invitation.
Yeah, Professor Pereira, I would I have a query for you. Suggestion maybe that this Spine 20 is Nepal included in this program, this Spine 20 initiative?
Professor, thank you for the question. The Spine 20 initiative, as I try to say, welcomes all the societies and all people interested in getting together. Professor Amit just submitted the application of the Nepalese Society to the advisory board, so to become a partner society. We'll be happy. I showed you that we had besides the 4 founding societies, we have at the moment 10 associate societies, and a lot of other pupils we as individuals. So it's a very inclusive initiative, and the most countries, the more societies we have, and journals and stakeholders we can have together, I think the strongest can be our mission. So this is really very important. So this is not intended to be like a kind of elite group or lobbying group or whatsoever. It will be as much stronger as the more wide representative we can have from all the world. Thank you for your question. That is really very important and welcome. Thank you.
Thank you.
So, well, I don't see any raise of hand here. But then definitely your comments, both Professor Scott and Professor Paulo had been very welcoming, and with Dr. Rudra's comment about the Government of Nepal initiative this year and the years to come is also welcoming. And we have known by now that definitely the low back ache problem, the back pain problem is the number one reasons for the global disability scales. And that's why we need to take care of it. And the patient-centric program is the key point now. So we should come across all the professional societies and try to work in the benefit of the patient. So do we have any other comments? Dr. Andre, would you like to comment anything? Dr. Rudra, yeah.
One thing I just forgot to mention is the lack of coordination between the agencies and different societies working on the spine pathology. So we also, there should be a good coordination. What I am feeling, there's a lot of associations like Spinal Surgeons Association, Neurosurgical Association, there is a association for spinal injury patients, and we're working independently. But we need to have a good coordination because all of us are working in the working for the benefit of patient and improving the quality service. So why we should not work together? That is the main issue which I wanted to say, but I forgot. Thank you very much. Let's work together. All the associations should work together. So that it becomes a priority program. Otherwise, if we are working differently, then nobody will notice. Because the issue is there's a lot of burden, there's a lot of disease burden, lots of disability, but the problem is awareness. People are not worried. People are not worried. To make it aware, we need to work together. We have to work together and we have a common voice. That's why I want to say. Thank you very much.
Very well said. Very well said.
I can add to that comment. I've lived long enough now. I can remember the days when neurosurgeons and orthopedic surgeons didn't talk to each other because they were competing. I can remember when neurologists, I happen to be a neurologist, and radiologists had big wars on who should read brain MRI scans. I can remember when chiropractors were not permitted to join spine societies. All of these things are broken down. It takes a lot of work, takes a lot of commitment by people, but there's no reason why we can't achieve a combined approach to help patients.
That's a history revisited, but then the step has been taken now, and I'm pleased to say that the Nepalese Society of Neurosurgeons, NESON, has invited literally all the professional organizations to this meeting, and we have been having these types of talks amongst each other. And it's very pleasing to know that almost all the professional societies, they have the similar concerns. But since our training is different and most of the professional organizations are being made to serve their members rather than their specialty, there's a difference. The professional organizations are made to serve their members. I'm not very sure whether they are made to serve their specialty, because if in case they are made to serve the specialty, then these questions may not ever come. Because the specialty always revolves around the patient, and whenever there's a patient care being discussed, then everybody has to come in tandem, in sync, and think only about one thing: how to give the best comprehensive care from all the other different modalities which is possible. So the steps are being taken, and it seems that a lot of different people from individual level, from professional levels, are very interested to take a key part. What we now need is definitely a plan, at least from Government of Nepal, a Ministry of Health and Population, to take a leadership here and then channelize all our inputs and energies into this particular model of care, so that we can also address to this number one global disability problem in a much organized and effective manner to our population. So with these words, I would like to thank all the participants, as well as the faculties from abroad, Professor Scott, Professor Paulo, and all other who had been there with us, Dr. Andre and Dr. Jeff, who had come all the way from Canada after a very long journey, and also having visited the innermost places of Nepal to let us know as to what would be the best way to solve this problem. And all of you, you are always invited again. On Sunday between 12 to 4 at Kathmandu Medical College, Sinamangal, we will have a TOT sort of training program on the GSI model, which will actually help us to understand this GSI model much more better. And of course, we can have another set of feedback session from you all once you go through this model again. So thank you very much, and hope to see you again in a much more better way. Coming up with a much more structured program and then cutting a ribbon saying that now we have actually started the program. Thank you very much.
Thank you.
With this, we've come to the end of our first session on initiative for its National Spine Health Program. I would like to thank our eminent speakers and our moderators for gracing us with such a comprehensive discussion. Now I would like to announce that we will be taking a 30-minute short tea break, and we will all be assembled shortly again for our inauguration ceremony. Thank you. So we will be assembled here at 6:30, exactly at 6:30 for our inauguration ceremony. Thank you.
Thank you very much. On behalf of Neurosurgical Society of Nepal Spine Chapter, I would like to welcome you all in today's conference. And today's inauguration program has officially begun. So we have planned to have this meeting in quite big scale, with physical presence of many more delegates from different parts of the world. But due to ongoing pandemics and rules and regulations of their institute, many experts, many delegates from outside canceled their physical presence. And however, they will be attending virtually and delivering their speech via Zoom tomorrow. As we all know, this neurosurgical neurosurgeons curriculum and training comprises almost half of the surgery, spine surgery. And almost every neurosurgeon are practicing this spine surgery in some extent. But there are some neurosurgeons, some juniors who wants to tilt themselves towards spine surgery and wants to become a spine, not a spine surgeon, expert in spine surgery. So that's why NESON has, under the umbrella of NESON, spine chapter was created, and this is the third tenure, running third tenure of this society. And from conventional spine surgery to, from past decades, the world is moving towards minimal invasive surgery. So, and if possible in our setup, if it's affordable, we need to adapt and train ourselves and to begin this minimal invasive surgery and to promote ourselves. So with this speech, and I would like to welcome you again. And then I would like to request our volunteers to welcome our dignitaries.
Thank you, sir. Firstly, I would like to heartily welcome Professor Dr. Amit Thapa, Organizing President of INSPINE 2022 and Vice President of NESON, to today's event. Similarly, I would like to heartily welcome Dr. Praveen Shrestha, the President of NESON, to today's event. Dr. Praveen Shrestha is not here in person today, but he will be joining us virtually from Virginia.
Namaste.
It gives me immense pleasure to be able to introduce our guest of honor for today's event. A veteran journalist, publisher, editor, writer, and a civil rights activist, we are graced today by the presence of Dr. Kanakmani Dixit. I would like to extend our warmest welcome to Dr. Dixit and invite him on the stage. Similarly, I would like to heartily welcome Dr. Balgopal Karmacharya, Chairman, Scientific Committee of INSPINE 2002, to today's event and would like to invite him on the stage. Similarly, we would like to extend our warmest welcome to Professor Dr. Bhola Thapa, Vice Chancellor of Kathmandu University, who has graced us with his presence as one of our guests for today's event. Thank you, everyone. Now, we are going to play our national anthem. Therefore, I wish everyone to rise up from their seats for our national anthem.
Shanti Bhumi
प्यारो हाम्रो मातृभूमि नेपाल बहुजाति भाषा धर्म संस्कृति छ विशाल मातृ राष्ट्र हाम्रो जय जय नेपाल।
Thank you, everyone. Moving on to officiate the inauguration ceremony, may I please have the pleasure of inviting our guest of honor, Dr. Kanakmani Dixit, to kindle the lamp of knowledge by lighting the banners.
या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या
Thanks to all our dignitaries. Now that we have officially inaugurated today's event, I would like to request the organizing president of INSPINE 2022, Professor Dr. Amit Thapa, to welcome all our dignitaries and guests. Thank you.
It's okay. Respected guest of honor, Shri Kanakmani Dixitju, Vice Chancellor of Kathmandu University, Shri Bhola Thapaju, dignitaries on the dais and the delegates here. It's a pleasure beyond which I can explain in my words to see you all here in person and having discussed about this spine thing in this August gathering. When we talk of spine surgery, we only think that the spine surgery is limited to a spine surgeon, but then that's not the case. There are a lot of other specialties which come across together and to work for this specialty. So before I start my talk, let me start with an invocation. Why is this not moving? Om Sahana Avatu Sahano Bonaktu Sahaviryam Karvavahe Tejasvi Nam Adhikonastu Ma Vidvishavahe Om Shanti Shanti Shanti. I just want to read it out for the guests who do not understand Sanskrit. It says, may we proceed together, relish together, perform our duties and actions with vigor. May we achieve brilliance through learning, but not hostility due to lack of understanding. Like there be peace everywhere. And that's what is the crux of all the things which we talk about. Because when we talk of collaborative meetings, we need to bring forth all the best which is possible in the world, which can be put forward to the best of our interest for our own people across our communities inside Nepal. So this year we are collaborating with the World Federation of Neurosurgical Spine Committee, World Spine Column Society, Association of Spine Surgeons of India, World Spine Care, and also Endoscopic Spine Foundation of India to bring forth the best of things which are occurring across the globe in the field of spine to all of us here so that we can exchange our ideas and experiences together. There are many uniqueness in different populations. The uniqueness not only in the terms of what we see in our population, but also what we see in other parts of the world. And henceforth, the exchange of ideas is the best way to learn from each other. So when we talk of the status of spine care in Nepal, I just did a quick short analysis as to what are the strengths and weaknesses and where are our opportunities and the threat we perceive can taunt us in future. So the strength, what we perceive right now is that we have a lot of trained faculties across different professional organizations with international exposure. And that is the best, because what we can see happening in Nepal is at par excellence treatment being given in the spine to the patients. And there are a lot of professional organizations which are actually helping bring forth a lot of new things to its experts. Then there are university affiliated programs, not only in graduate, but also in postgraduate courses and fellowships being offered these days. And hospitals are interested in investing. That is again the best part, where we can see a lot of new technologies coming up. Now in Nepal, we have robots, we have navigation system, we have intraoperative neuromonitoring system, which was not even thinkable a decade back. Now all those systems are here in Nepal. So there are a lot of good strengths, particularly in terms of strength of these surgeons providing care to the patients. But definitely their weaknesses are also there. Most of these services are scattered. Few require centralized services, but most diseases, they need to be decentralized. And henceforth, a proper referral system is what utmost care, and that has to be on a base of some evidences-based practices through which the referral pattern can be well developed. Common problems, if not solved acutely, become chronic. And this is very true in backache, when the acute problem, if in case it is not solved, not prevented in the initial part, then it can become chronic and keep nagging throughout their lifetime. And of course, these problems are much more organizational than individual. And research and audit are still in a very nascent phase. There are many people who are doing a lot of good researches, but then it has not come up to an institutional level. And then therefore, there lies many opportunities in terms of organized services, which are utmost care. Now the days are gone that a doctor would sit in a small clinic and offer all the services. Now the days are in where we need to collaborate and work under a single roof, provide a comprehensive service to the patient. And then the in thing for the modern neurosurgery is daycare services, minimal invasive surgeries, where a patient with minimal morbidity can be served and can be discharged as soon as possible, so that the person can go back to his or her life and can perform his duties towards social society as well as for his own good. And also evidence-based protocol, even though those need to be customized for each patient, need to be followed. And these, if in case not served on the right time, the threat is always there. And the threat is that a chronic problem, particularly like backache, once it's there, it's difficult to treat. And it actually involves a lot of disease-associated life years wasted. And that's why the workforce of the Nepali population will be affected. And because of this, non-standardized and non-tested practices are flourishing these days. We can see a lot of adverts across the roads and then being thrown on our internet as well as through the audio services. And this can actually lead to the failure of trust and litigation once the public do not find the services to their own demand and to their expectations. So the theme of our meeting, that is towards excellence in spine care, does not only deal with the excellence of in personal, our own professional life, but also at the community level, where we can bring this excellence to the community level, to their own doors, where the people require the services. Through the excellence in research and audit, as well as excellence in post-treatment care, and also over top of all of this excellence in humanly care, because after all, it's all about patient and the disease. We are just a service provider who are trying to give our best to the patients. Equality in representation is very much accepted and become an integral part of our Nepalese constitution. And henceforth, we believe that every person who is sitting in this room or hearing to this meeting has its role in the contribution of a spine care. No work is small, that what we need to understand. The place where you work is unique, and hence your contribution is also unique. And that's why it is the responsibility of us to be the best, but always remain a friendly doctor. And the authenticity of the research and the audit is our individual responsibility. No one should expect a government to look for what all researches we have done, because all those we actually publish is basically the data. This data speaks for the nation, and that's why our authenticity on research and audit is our own individual responsibility, and that should be taken by all of us. So at the end, I'd like to invite you all to this meeting, and hope this meeting will serve all of us, are the expectations and the goals we have perceived through this. And with this kind word, I'd like to again invite you to this meeting. Thank you once again.
Thank you, sir, for such an impactful words on spine care. Moving on with the event, we have with us Dr. Bal Gopal Karmacharya, Chairman, Scientific Committee, INSPINE 2022, to shed some light and present in front of you all a detailed introduction of today's conference. Thank you.
Good evening. Respected chairperson of this inauguration ceremony, Professor Amit Thapa, our chief guest, Dr. Kanakmani Dixit, Vice Chancellor of Kathmandu University, Professor Ola Thapa, our dignitaries from home and abroad who are participating in this conference, ladies and gentlemen, once again, I'd like to welcome you all. After a hiatus of almost 2.5 years of the COVID pandemic, we are here once again physically joining in our efforts to take spine care to the next level. In the morning today, we had pre-conference hands-on cadaver workshops on kyphoplasty, vertebroplasty, and unilateral biportal endoscopy in Kathmandu Medical College Community Hospital. We had around 20 participants, both residents and junior consultants, who learned how to perform safe procedures in the lab. In the afternoon, just before this program, we had the Initiative for National Spine Healthcare Program. We discussed the current global burden of spinal diseases and about the global spine care initiative and how we can implement this spine care program in Nepal. Now we are having this inauguration. Tomorrow, whole day, we are having theme-based spinal symposia on the state of spine care and motion preserving spinal surgery in collaboration with Association of Spine Surgeons of India, consensus meeting in spine surgery, and lastly, on minimally invasive spine surgery and spine endoscopy in collaboration with World Spinal Column Society and Endoscopic Spine Foundation of India. Curing patients with spinal problems is a multidisciplinary task. It's not a one-man show. One of the major focus of this conference has been to showcase the multidisciplinary spine care model developed by World Spine Care that we are trying to get the health ministry to implement at the national healthcare policy level. In addition to it, we are also emphasizing for the rapidly developing endoscopic spine procedures, which are found to be more effective and with rapid recovery and less potential complications to the patients. We also have award papers where we have papers from neurosurgery and also from allied specialties. So this conference is a complete package of wide-ranging but concise topics that are relevant today. And we would like all of you to enjoy the conference. Thank you once again.
Thank you very much, sir. Your words have certainly invoked in us a greater and deeper understanding of today's event. Joining us live from Virginia is the president of NESON, Dr. Praveen Shrestha. May I please request Dr. Shrestha to share a few words with us about today's event.
Namaste and hearty greetings. I believe I am visible in the screen, and I am Praveen Shrestha, currently serving as the president of Nepali Society of Neurosurgeons, NESON. Respected chairperson, chief guest, dignitaries in the dais, respected seniors, colleagues, all the delegates and participants of this conference. It's my great pleasure and in fact honor to put my few words on behalf of Nepali Society of Neurosurgeons, on behalf of the organizing committee of this event, and on my own behalf in the context of this second International Spine Conference of Nepali Society of Neurosurgeons. At the same time, I am feeling extremely sorry for not being able to be present physically in this August gathering in this vital event, because currently I am not in Nepal. Currently, I am out of Nepal. And thanks to this virtual technology, Because of this technology, I've been able to communicate with you all from the opposite hemisphere of this globe. Well, first of all, I would like to welcome you all once again on behalf of this organizing committee and Nepalese Society of Neurosurgeons to this International Conference of the Spine. Well, talking about spine, I remember those days when I was a high school student, almost 36 years back. त्यति बेला स्कुलमा पढेको थिएँ नर्भस सिस्टम भन्ने हाम्रो शरीरको एउटा सिस्टम हुन्छ जसले हाम्रो शरीरलाई चलाउँछ भनेर. Then that time I also had read that the nervous system is composed of basically brain and spine. Spine is not only spine, it's a spinal cord. Brain र spine मिलेर हाम्रो nervous system बनेको हुन्छ भनेर. Then when I started neurosurgical residency almost 20 years back, that I knew spine is one of the vital part of the not only nervous system but also the human body. त्यसपछि जब neurosurgical practice गर्न थाल्यो, then I understood, now I can realize how important is spine and spinal cord. त्यति मात्र होइन रहेछ. It is not only that the brain and spine are two essential components of the nervous system, but it is the more importantly, it is the two essential components of our daily routine neurosurgical practice. From early in the morning till the evening, till we finish our work in a day, every day we deal with the brain and spine almost equally. Since the early stage of our career and since the early stage of our residency, we are exposed almost equally to this both brain and brain and spine surgery. So most of the neurosurgeons in our country, and I believe probably it's the same in many parts around the world, we neurosurgeons, we continue brain and spine surgery almost parallelly and simultaneously till the end of our career, as far as our knowledge, skill, and expertise allow us to do. Well, everybody knows spinal surgery is also performed by another medical professional. They are also equally good spinal surgeons, but most of the time they'll deal with traumatic cases, and the instrumentation is the main surgical procedure. In many instances, they mainly deal with the nervous structure which are already damaged, which is already injured, and their main concern is usually the mechanical stabilization. But we are neurosurgeons, we are neurospinal surgeons, and we deal with the nervous structures which are still normally functioning. We deal with the spinal cord, we deal with the spinal nerves, we deal with the nervous tissues which are still viable, which is still salvageable. So as a neurosurgeon, we are more concerned with the functional restoration of the spine. We are more concerned with the neurological function of the spine, not only its mechanical stabilization. So that's the big challenge that we face every day. That's the big challenge that we face every time whenever we perform spinal neurosurgical procedure. Therefore, a qualified and skilled neurosurgeon can deal with not only the traumatic cases, but wide varieties of neurosurgical spinal problems, like critical spinal surgery, like spinal tumors, intramedullary spinal tumors, congenital spinal anomalies, which are much more difficult. In those cases, we need to deal with the neurological function, not only with the spine. So in wide varieties of this type of spinal problems, we neurosurgeons, we can deal with promptly, appropriately, and more skillfully. Thus, spinal surgery is not a separate entity for us. Rather, it's a vital part of neurosurgery. Without spinal surgery, there is no neurosurgery, I would say. Without spinal surgeon, we are not a neurosurgeon, I would say, because almost half of our neurosurgical work is spine. So I think we should call it neurospine rather than only spine. I think we call neurospinal surgery, not only spinal surgery. I think we should call neurospinal surgeon, not only spinal surgeon, whoever is dealing with this type of surgery. Having said this, well, we need to specialize, we need to sub-specialize ourselves in varieties of sub-specialties within neurosurgery. We need to train ourselves many times. We need to educate ourselves many times. We need to deal with the newer technologies, newer techniques, newer instruments every time. So I believe this second International Spine Conference is a step towards fulfilling this aim. I believe this conference is towards re-educating ourselves, retraining ourselves in the field of this spinal neurosurgery. Well, our society, Nepalese Society of Neurosurgeons, always encourages our members, especially the young members, to sub-specialize in varieties of neurosurgical subspecialties, keeping the whole neurosurgical practice integrated. Well, I can see spine chapter of our society has been working very hard in creating more knowledge, skill, and interest in this particular field of neurosurgery. I believe this conference will motivate our young neurosurgeons to develop this career in this particular field. I also believe this conference will further promote friendship and collaboration between the spine chapter of NESON and all the other national and international partners. I would like to request all the participants of this conference for the best effort for their active participation in this conference. I would like to once again welcome all the delegates from Nepal and abroad to this conference. I would like to thank all the members of this organizing committee. I would like to thank the supporting institutions and organizations for their great support. And finally, I would like to extend best wishes for the successful completion of this conference. Once again, begging pardon not for being able to present physically in this conference. I would like to thank you all once again. Thank you very much. Thank you.
Thank you, sir, for sharing your words with us. We feel more than honored to be in the gracious presence of dignitaries from all walks of life. One of such dignitaries is our guest of honor, Kanak Mani Dikshit. In order to introduce our guest of honor to our audience, may I please request Dr. Raju Dhakal on the stage. Thank you.
So, good evening, ladies and gentlemen. I feel privileged to be here in this evening. So, today I am going to present about the chief guest in front of chief guest. So, I feel a bit nervous. Anyway, I'm going to start. So, I like to say like a journey of Lily Veer to Spine Injury Sangh Nepal, a Kanak Mani Dikshit, a founder chair of Spine Injury Sangh Nepal. So, I am Dr. Raju Dhakal, medical director at Spine Injury Rehabilitation Center, Saga. Okay, short biography about Kanak Mani Dikshit sir. So he's 66-year young gentleman, and he's journalist, writer, activist, reporter, and editor as well. So he likes activism, and he's famous in many, activities like spinal cord injury, public transport, archiving a Madan Puraskar, children's author, translating BP Koirala, Atma Vitanta, and many more. So he is also the supporter of trekking alone since 1971 when he was 16 years old. And he traveled alone in Italy, in Gran Paradiso, where he slipped and fractured right tibia and fibula. And again, when he was in Manang and Lumjung Annapurna circuit trek, again alone in 2001, again he fell off from the cliff and broke his neck. And at that time, he fell down around 150 feet down in the Lirivir, and he had to spend, 3 nights, 4 days. That was very terrible time. He has to be in the middle of the hills. You can go through. When I had fractures my leg, and the Kanak sir came to my house and he gave me Maile Dekheko Muluk. Then if you go, Maile Dekheko Muluk Parnu Bhayo Bhane, then you can see how he was suffered at that time, when he has to spend in one heels 3 nights, 4 days. So, and at that time, he has many hurdles, pain, which I cannot explain here. He has C6, C7 fractures, but fortunately, his spinal column remained relatively intact. And surgical stabilization was done, and he was rehabilitated. You can see the Lily Veer right of the presentations, and he was in the down. There was Marsangdi, rower of Marsangdi, and in the up
it's like a very steep hills, and he was stuck in the middle for 3 nights and 4 days. So this is just pictures. At that time, he was rescued, and late Professor Upendra Devkota, you can see pictures, and he was treated in Bir Hospital. Then some tractions, and even with the traction, he enjoyed his life with families, with celebrations of the festivals and doing work. So after all these, with the founders here, Kanak Mani Dixit and Santa Dixit, his wife, and Dr. Anil Bahadur Sester and his colleagues thought that we should have at least one specialized spinal injury rehabilitation center in Nepal, and then the spinal injury song Nepal coined. So, and it was inaugurated in 2002 by late Sir Edmund Hillary. And the Kanak always used to say, like, the poorer you are, the harder you fall. If you read that book, then only you understand why he said like this proverb. So the mission of this center was to enable persons with spinal injury to realize their rights to live as independent as possible in their communities through, by psychosocial approach, advocacy, awareness, training, and skills development, with the vision of to become nationally and internationally recognized as a center of excellence. So after that, Spinal Injury Song Nepal had one spinal injury rehab center, which is, and another is vocational center, and we have other projects as well. So these pictures you can see, spinal injury rehabilitation center is of specialized non-profit, 51 beds, and recently we have added traumatic brain injury and stroke 10 beds as well, because of needs of countries, and this with support of the government of Nepal. And also we have inpatient facilities, outpatient facilities, community-based rehabilitations, outreach activities, and recently we added tele-rehabilitations. And at the same time, we do a lot of training, research, and advocacy policies for the betterment of the spinal cord injury. And what will happen? We are providing services at the hospital level, but we need to think about what would they do when they go back to the community, right? Then our chairperson envisioned that we should have some vocational training centers so that we can bring them here and train so that they can be economically empowered. So that's why we have vocational center in Sangha, where we provide vocational training to spinal cord injury and physically disabled people. And so far, 70% of the trainee were economically empowered because of our vocational training. So the journey is and will be continue. So thank you so much, NESON organizing committee, and I'm sure rest of the thing in detail will be, delivered by Chief Guest Kanak Mani Dixit, sir. Thank you so much.
Thank you so much, Raju sir, for such a wonderful introduction. After witnessing such an impactful introduction, I think I speak not only for myself, but for everyone who's here in this hall today, that we can't wait to hear a few words from the man of the hour himself, our guest of honor, Kanak Mani Dixit sir. May I please have the absolute honor of inviting sir on the stage to share a few words with all of us.
Dr. Thapa, Dr. Karmacharya, Dr. Raju, as well as doctors in this hall and online overseas. Greetings to all of you. I could say I'm speaking also as a representative of the Spinal Injury Rehabilitation Center. And I have been introduced more than once today as doctor. I could tell you that perhaps I have become doctor by osmosis, being in the same hall as all of you. But I have to confess to having a more mundane life as a journalist and a writer and an author. Although, like everybody, I have aspirations to be a doctor, whether medical or with a doctorate. But no such luck comes my way because I tend to focus on falling off cliffs. And that is my specialty. As was explained earlier, besides falling off at different times without injury and not told to family and friends and wife, the 2 times I could not evade scrutiny of a fall was indeed when I fell off the Grand Paradiso, which is the tallest mountain, or in Nepali, Himal of Italy. त्यहाँ चाहिँ नि मेरो टिबिया र फिबुला ठनक्कै भाँचिएको थियो अनि त्यसपछि आएर exactly 20 years ago, falling off what is known as Lily Bhir. So for that reason, I must tell you that generally people live their lives, unless they have a spinal issue, not bothering too much about their spines. But I have had special reason to be sensitive to, firstly, my own spine, and therefore, and as a corollary of that, or extrapolating the spines of others. And which is why I guess I was enthused with some friends to start the Spinal Injury Rehabilitation Center, following the spinal injury that I had, C6, C7, and I think T1. After Dr. Upendradev Devkota treated me, when we did make a trip to the US, a neurosurgeon friend in Nyack, New York, said this was what he termed a cord-sparing injury, meaning the vertebrae were shattered, but the spinal column remained more or less intact, so that मेरो यो 3टा औँला दुईतिरको राम्ररी चल्दैन, बाँकी मेरो हेर्ने मान्छेले केही भएको बुझ्दैन, खाली मोटर ब्याक गर्दाखेरि र तकियामा टाउको राख्दाखेरि दुःख पाउने त्यति बेला मात्रै हो. नत्र भए I have been lucky, as one article described my episode. It was not only injury. First, it required a discovery, because you're somewhere in the mountains amidst forests and cliffs. So first you got to be discovered. Then you've got to be transferred. Then you've got to be treated. Then you have to be rehabilitated. And in Nepal, how many people have the privilege to access all these stages? And that is indeed why we felt in the year 2001, we realized that Bangladesh had got a spinal injury rehab center in 1971, but till the year 2001, there was no spinal injury rehab center in Nepal. And that is why with Dr. Anil Shrestha, an orthopedic surgeon, Shanta Dixit, a PhD, a public health DRPH, myself and a few other friends got together to start this center. And I believe what is interesting about spinal injury in Nepal, which struck us back then, beyond the privilege of someone like me, was that Nepal is a country of cliffs and rocks. And when you fall, you tend to fall not on mud, which is what would happen if you fell off a tree in Bangladesh, but you fall on hard rock here. As a result, and then मान्छेहरु स्याउला टिप्न जानी हो, जंगलमा घाँस काट्न जानी हो, जंगलमा अनकन्टारमा एक्लै गर्ने काम हो यो. त्यसैले the discovery indeed becomes a problem. After that, transport. There is a term, Nepali is a language rich in onomatopoeia. The term in Nepali is Chakuljhai. It is pronounced differently in different parts of the country. But essentially, Chakuljhai is a onomatopoeic term to describe the jostling with which a victim of spinal injury is carried to whatever kind of facility may be available. And sometimes this carriage is on a wickerwork basket with the spine bent, because that's the only way you can sit on the basket. So transport becomes a major problem. Also because of lack of training across the country, what people know how to do is to show their concern rather than try to provide required support and stabilization to the victim of a spinal injury. So you come to the base of a tree, somebody is there, you show your concern because what you think, and it's because of your lack of information and training, you want to show your concern because since this person is in such pain, you feel that if I show my concern, at least that is giving him or her something that he or she doesn't otherwise get. So what do? I jostle the person and perhaps, or more likely than not, give further injury to the spinal column. And these are the reasons why we felt a spinal injury rehab center was required. Back then, back in 2001, quite a few orthopedic surgeons were transitioning to become specialized in spinal surgery as well. But what would happen was the doctors, the surgeons, and the support staff never got the kind of satisfaction, or rarely got the satisfaction of seeing their patients do well because of rehab. Because the doctors, they do the best they can on the patient, and then you send them onward because there are more patients online for surgery or treatment. And that is where we felt perhaps we played a role back then, and that we play a role till today. And of course, we are not the only rehab center. I believe we are probably the only public rehab center, at least in the valley. But there are now private sector rehab centers, which is also a good thing. But you need to have some kind of a standard setting by a public institution, which also then helps the entire sector to move ahead in quality and with social justice to the patients. And I believe that's where perhaps we have managed to play some kind of a role. एउटा कुरा चाहिँ मैले भन्नै पर्छ, अब सबैजनालाई अलिअलि तलतल हुन्छ तिम्रो एक्सिडेन्ट चाहिँ नि कसरी भयो भनेर, हैन? अब तपाईहरुले मेडिकल कुरा र रिह्याबको कुरा इत्यादि त अब कन्फरेन्सै के अरे इन्स्पाइन भनेपछि इन्टरनेशनल स्पाइन हाइब्रिड चाहिँ नि के हो मैले बुझाएको छैन किन हाइब्रिड भने, तर कन्फरेन्स त हो। तपाईले आफ्नो स्पेशलिटीमा त कुरा गरिहाल्नुहुन्छ, त खसिस कसरी भनेर सोध्नुहुन्छ होला मलाई, म त्यही बताउन चाहन्छु छोटकरीमा। हुन्छ डाक्टर साहब, म चाहिँ नि as Dr. Raju suggested, I decided back when I was 16 years old in 1971 that the thing to do was to trek through Nepal alone, because the trekking alone gives a kind of a build-up of adrenaline and blood to the brain, creativity, etc. Besides being fun to go through different terrains of Nepal, different ethnic terrains, different geographical terrains, from the Tarai up to the mountains. So I decided my particular specialty was to trek alone. अनि त्यही गर्दै थिएँ मैले, धेरैचोटि गरेँ, अनि एक दुईचोटि खसेँ पनि, लडेँ पनि. But then in 2001, I was going around Annapurna circuit with my son up to Jomsom, and then I did the Annapurna circuit the other way, which means from Muktinath up to Thorangla, down to Dharapani, down to Germu, towards Besisar. त्यही बेलामा अब हतार थियो, बस काट समाउँछु भन्ने थियो. I do not know the last hour of my trek, but of my walk, but apparently because I was trekking in the monsoon, so it was August, and the trail was cut out of the mountainside, so there was a waterfall over the trail. So to skirt it, I was going around the side by the looks of it in Lilibir. I slipped and I fell. I do not remember the 1 hour previous to the fall, but I remember flying. I remember trying to clutch the ledge and then tumbling and then falling down and lost consciousness until the bright August sun caught me in my face. I woke up. I tried to get up. I couldn't. I tried to get out of there. It was not possible because I was on a ledge that was on a tilt that was tilted towards the Marsangdi River, another 150 feet below me. And it's a sandy place, so I was scratched all over my body. I tried to get out, but it was clearly impossible, and excruciating pain to my neck. Ani मैले के डिभाइस गरेँ भनेदेखि त्यो मोजा, woolen socks, Eastern Mountain Sports. I remember even the make. त्यसलाई चाहिँ नि पानी परिरहेको थियो, एकदम गोलो पारेर बल्झिएको पानीले भरिएको मोजा यहाँ यतिमा राखेपछि चाहिँ नि अलिकति पेन, and if I did my hands in Sivasan mudra, दुख्ने कम हुन्थ्यो. So I devised a way in which pain was lessened in the hill itself, but I kept slipping towards the cliff. So I found a log to lock my leg against, and then I also found a tuft of grass to grab into. That tuft of grass turned out to be also an anthill. So I was bitten by ants all over my body. Once an animal walked over me, I shouted as best as I could so it wouldn't come back. A couple of times I saw eagles and vultures above and wondering what would happen. Across the Marsangdi, there was a village and it was monsoon. I found a plastic and I put it into a stick and I tried to, because I couldn't move, I tried to put it on my tummy and wave the flag up. But it was monsoon, which means people are not going out to cut grass. So nobody was out to look at me. Early, I heard voices, which means that there are people up in the trail where I had fallen from. But this being the time of the Maoist insurgency, people, I found out many years later, they had heard me shout, but they didn't dare come out because they didn't know. That is the kind of society we had become in the year 2001. The conflict ended only in 2006, as you know. So when I did try to get out, it was not possible because there were more cliffs all over. But finally, on the fourth day, and now I won't go into the story of my rescue, many great coming together of good fortune meant that I was found because my cap had flown and got stuck on a tree. So when they looked down the cliff, they saw the cap. They came down expecting to find essentially a body because they could smell it. But the smell was my scalp was open, and it was 4 days of an open scalp that was smelling. So they located me, and then they located a local villager who came down on ropes, carried me on his back up to the trail from where I was helicoptered out. But the gentleman who carried me up picked up his load and went off to back on his trail to Manang, carrying loads. It took me many months to find him, and today I am great friends with him, Lok Bahadur Lama of Gorkha. I will now come towards the end. This was just a little bit of a side story because everybody loves stories, except in my case, it is a true story, I assure you. What I think we found, the reason we started the rehab center was because Nepal didn't have a rehab center. And also, as Dr. Raju said, we realized that firstly, the bulk of the people who get spinally injured are those who fall from height, as you call it in your technical parlance. So fall from trees, especially women, because for some reason in Nepal, it is the women who climb trees unprotected in a pharia or a dhoti to cut tree fodder, because there is not enough fodder on the ground. And when they slip and they fall, so the percentage of women with spinal injury tends to be a little higher than men. Then, of course, there are porters, there's cliff sides, there is terraces and kanlas to fall from, and the fact that this is a rocky terrain. That's why the slogan, if you will, the harder you are, the poorer you are, the harder you fall. Jati jati bipanna uti saro chot. I believe that within this one saying, there is sociology, there is political science, there is history, and of course, there is the subsistence living in our villages. What has happened lately, however, especially as Dr. Raju will also confirm, 3 years ago, the intake into our center, the spinally injured from accidents overtook fall from height, which means that there is, as you know, the incidence of road traffic accidents in Nepal is horrific. And it's only because of a certain lack of sensitivity of our civil society and the relentless political chaos in our country that we have not been able to focus enough on this daily tragedy of road traffic accidents. So if there were one message I would share with you as a fellow traveler in the road to spinal recovery and spinal care, we must all spend a little bit of our time to talk and to talk up the topic of road traffic accident. The way I got to realize how bad a bus, the way a bus is built in Nepal, in Butol, in Banepa, त्यो त सोल्डर गरेर फलामलाई रसाएर जोडेको मात्र न हो, nothing is molded. This I got to know when I visited the blast site of the Madi bus blast. When the Maoists blasted the bus that killed about 47 people in Badarmure in Madi, with my interest also in spinal injury, when I saw the wreckage of that bus, I got to realize something that is important for me, for my study of spinal injury, which is that the seats has crumpled. There is no strength in the seats that are made in our buses. As a result, when a bus falls off a cliffside, when a bus bangs against another bus or against a hillside, the way the seats crumple are designed to destroy your spine. This is, for me, a subject of vital importance for our people. But this is a subject, as far as I know, has never been studied from the perspective of spinal injury. So I believe there is a lot to be done. There is a lot to be done in improving spinal injury rehab, introducing it all over the country. There is a lot of need for further research. You are, as spinal care and spinal surgeons, neurosurgeons, you are absolutely alert and aware to the advances around the world. But I feel that now it is also possible to do advances within our country because the technology is here, the commitment is here, the specialization is here. Together with the specialization that you neurosurgeons and others do in the theater and in the hospitals, might I suggest that there is also a need for research and deeper learning and deeper sharing in spinal injury rehab. That is an area where perhaps we also can contribute to the world. Not just that we forever take from the world, but we also give to the world. I will give you one example. In the spinal injury rehab center, we keep the caregiver with a little temporary bed, which is pushed under the patient's bed, but they are in a ward setting and the caregiver is also there, so that they also learn for caregiving when the patient returns home. But what we have realized is what is different in the spinal injury rehab center in Nepal vis-a-vis spinal injury rehab centers I personally have visited elsewhere, particularly in Europe, is that the mood is different because there is a community, there is a family, there is a ward. Even the supine patient is listening in on conversations. Sometimes there is gossip. Sometimes you also see others faring as badly as you, or sometimes worse. You are also taking mental support from all that is happening around you. I might suggest to you that this is a formula or a format of treatment, rehab, that might be shared with other countries. So we need not forever be only takers. We should also be givers, even as we improve spinal care in the surgery chamber, in the hospital bed, as well as in the rehab center. I think I've come towards the end. Let me see in my notes if there's anything extra. that I might, and I must say the people at the back that when you keep talking, it does disturb the person who you've invited to speak here. So it's important to pay a little bit of interest to what's going on at the podium, even if it's a little boring. I apologize for that. I feel there is a need for collaborations. There is already a lot of collaborations, but in the past, there were not enough surgeons and rehab doctors and nurses and specializations. But now in Nepal, I feel there is that threshold number does exist. And for that reason too, I feel perhaps in the days ahead, we must look at collaborations across the disciplines of spinal, but also from academia, from road engineers, to sociologists, to volunteers, to activists that focus on from humanitarian care. I believe Nepal is in for more spinal injury and other kinds of spinal trauma in future. And for that reason, I am happy that people like you already exist, and people like you are also happy to do a conference, which means sharing. A conference which means you learn from others, but you share with each other. You're not in individualized silos. That, I think, is what our society needs. We need to take from the world and we need to give to the world. Thank you.
Thank you so much, sir, on talking about spine care, sharing such impactful life experiences with us and giving so many ideas and suggestions. It is always a pleasure listening to you. Moving on, as we are in the process of getting to hear from our dignified guests, continue with this process. It gives me immense pleasure to be able to invite Professor Dr. Bhola Thapa, Vice Chancellor, Kathmandu University, on the stage to share some few words with us. Thank you.
Namaskar. Chairperson of Nepalese Society of Neurosurgeons, Professor Amit Thapa, very distinguished personality of this society, Mr. Dixit, Dr. Karmacharya, the person who is in online connections, Dr. Srestha, distinguished participants, ladies and gentlemen. I was talking with Dr. Amit Thapa yesterday, and then I was asking whether I am a relevant person to be as a guest of honor and then to be here or not. But in my life, I got a very big opportunity today to hear the real story of Mr. Dixit about his accident. And sir, it's really means it's a really opportunity for me, because why I would like to say real opportunity is I had a plan to go for Annapurna circuit that week, because that was the time when we had a vacation, but my family didn't allow me after your accident, and I have not been able to go on that circuit even now. So see what opportunity, and I had met him so many times. I had never heard his story from his own mouth. Sometimes it's a rare opportunity even for us, the doctors. I think you might have heard several stories like that. Again, that I'm not a medical doctor, because sometimes maybe again that even if you say that I'm a doctor, I'm an engineer by profession. I'm leading the university, but I'm really delighted to stand in front of you, congratulate you, and then even I don't know, I can assure you or not, but at least when I'm leading a university, whatever you are thinking, what the future which you see, I will also be together with you. And I'm really glad that in one of the strength of the
this spinal issues that you have said, like universities are on that, like the universities are affiliating the programs. I'm proud of the institution which I am leading, even if it's a small university in Nepal. I'm proud 40% of the registered medical doctors of this country is produced by Kathmandu University. And I got an opportunity to lead that institution. And there are professors who are working, and then it's not just a primary healthcare, but we also have a super specialty medical education in this country. Of course, the access was a issue. We have now some access. It's time now, like what is the quality of that service and that education? Definitely, collectively, we can work that we make it of world class. Mr. Dixit also challenged me, like when I think he has not challenged me, but challenged my profession, like when he was ending his speech today. When again, that as I said, even yesterday evening, I was talking with the president. I said, maybe I should not come here, but I'm glad, I'm proud, I'm here today. When I am coming here, sir, I was just following a Facebook, my researcher, my PhD student, today he is attending another conference, orthopedics and orthodontics conference, a mechanical engineer. I saw it on a Facebook. Even he had not told me he's attending that conference. Of course, I'm a mechanical engineer trained for development of hydropower. I have spent my 30 years for working on a hydropower, but recently I have been focusing my research on, I will not say the medical issues, but at least I'm on that line. So my master's research students are on on prosthetics. So my PhD students, which I mentioned, he is doing his PhD on artificial knee. Some of my colleagues whom I support is on health informatics. It's not because that I was trained on those areas. The organization which Mr. Dixit is leading, like a spinal injury rehabilitation center, unknowingly I was leading a project to develop a wheelchair in this country itself. So we inspired a mechanical engineer to do his master's thesis, master's by research on wheelchair. Like, of course, we can bring very good wheelchairs or aids, but whether that can be afforded by the poor people or not. So if we can contribute something, so without knowing, like there could be opportunity or there could be a need for such things. We at Kathmandu University, even myself, that I was doing, and I'm really glad when I see the picture of spine. Of course, earlier, as the Dr. Praveen Shrestha, he said when he was studying school, he said like we have a nervous system or nerves, but I was saying it's a skeleton system. But for me, that is the most complex mechanism. For a mechanical engineer, that spine is complex mechanism. The fingers, he said, like his 3 fingers doesn't work properly. That is the most complex mechanism. I cannot design a robot if I don't know the fingers. So it's a time now, sir. We have started a medical education in this country. Started from a very primary education. We have reached up to the highest degree of the MCS and DM. And my contribution for medical education as a vice chancellor is now we have to combine engineering and this medical and a technology. Otherwise, technology is coming up. I was fortunate to be in India last week, attending the Vice Chancellor's conference. I happened to be in touch with several medical doctors, and they said, of course, there are very much inventions and then developments in medical industry, especially for the service, but we cannot pay. Many people of either India or Nepal, they cannot afford that. But we as now the professionals of this part of the world, if we can bring down the cost, of course, that may not be that much of sophisticated and that may not be that of high quality, but it's need of the time now, like we have to make them affordable and available to people who are living in the rural area. So my commitment will be, sir, through your society, please, whatever university can do to bring the technology and medicine together, I'm open on that. And definitely in the university, until now, it's only School of Engineering. These projects are on, but I have also promised to some of my colleagues in India also, and some colleagues here in Nepal, I will start a joint program on a master's and PhD level on medical and technology, bringing together. So hope that it will change the landscape of education. And as Mr. Dixit was mentioning, we may be able to serve to other country also. So one of the example is like in Tilganga Eye Hospital, what Dr. Ruit is doing, producing some component here and sending it outside. That means there might be several opportunities that we can do together. That's my promise, sir. And then again, lastly, like as a mechanical engineer, of course, you are treating when the patients, when the people get injured. But we as engineers, we take a responsibility, sir. Those are a sort of a death traps. I know, I accept that. Not only bus, several components, engineering components. So at least if we know that, if engineering students, practicing engineers know the importance of that, definitely the product which they will design will have some arrangement so that even if the accident happens, that there will be a minimum impacts and this thing. At least this sort of a thought, even for engineering education, we need to come out of the conventional engineering education. So this sort of interdisciplinarity and then the culture of cooperation is needed globally as well as in this country also. And as in the capacity of Vice Chancellor, I promise in my capacity, I will do everything so that we not only just talk, but we will make it happen. Once again, I would now really thank you for inviting me in this conference, because I also learned, even if I have not been able to attend the session, but it has inspired me. Thank you very much.
Thank you very much, sir, for your insights. It was indeed a pleasure getting to listen from you. We've almost come to the end of our formal session of our inauguration ceremony. To convey a vote of thanks, I would like to once again invite on the stage Dr. Samir Acharya.
Thank you. Here we come to the end of this inauguration program. I would like to thank all the chief guests, delegates, and all my friends, colleagues, seniors for attending this program. We'll be having another symposium which start at 8 tomorrow. So I will request you all to be there on time. As mentioned here, the surgical treatment of spine is a mechanical work, and there is a bigger role of dedicated nurses, physiotherapists, psychologists, and other experts, rehabilitation experts. So I would like to thank all those allied, all those who have participated in afternoon conference. And then I would also, it's a basically teamwork, and our aim is to send the patient back home without any deficit if possible, and let him back in his work. So thank you very much. And this time we are very fortunate to have the meeting in collaboration with WFNS Spine Committee, World Spine Column Society, Association of Spine Surgery of India, and World Spine Care. And I would like to thank all the organization. And I would also like to thank our chairman, organizing chairman, Dr. Professor Amit Thaba, who had really worked hard to happen this. And he had been in communication since last many months. Thank you very much. I would also like to thank Dr. Balgopal Karmachare, Chief of Scientific Committee, and he has been working very hard. And this morning we have a workshop on kyphoplasty, vertebroplasty, and also endoscopic biportal surgery, of spine surgery. So I would like to thank the Professor Malcolm Pastenzi, who was a tutor. And I would also like to thank the KMC team forensic department, Dr. Zenos and his team for providing us the fresh cadavers. And thank you very much. And without taking much of your time, please enjoy the conference. And I hope you all are hungry and thirsty as well. Please enjoy the cocktail dinner. Thank you very much.
Thank you, sir. Before the social dinner, we now move on to a rather informal part of today's evening. Coming up next, we have a few items of dance and music prepared and presented in front of you by the students of Kathmandu Medical College and Teaching Hospital. Enjoy.